We have a full day for you today. I'm going to introduce to you Colleen, our president, and she's going to tell you the schedule for the day, and then we're going to get started.
Do I look into there?
Yes,
they can see. Oh, yeah, I see. Okay. Get a little closer. Okay. Good morning. I'm with Euthanasia Prevention Coalition USA, and I'm very glad we're going to be able to have the opportunity to present so many speakers. This is going to be so informative. I'm going to be taking a lot of notes myself. So first, I think most people here may know Alex Schadenberg. He is the executive director of Euthanasia Prevention Coalition. Okay, then we also are going to have Edward Rivet from the Advocates for Better Care Michigan, Genevieve Marnon with Senior Policy Analyst, the Advocate for Better Care Michigan, and Mr. Peter Wolfgang, he's the Executive Director of Family Institute of Connecticut, and Meghan Schrader, she's with EPC-USA, a board member. And we're also going to have, then we'll have lunch. Then we'll have Wesley Smith, and he'll be here speaking, the writer. Then, I'm sorry, and he's a fellow at the Discovery Institute's Center on Human Exceptionalism. Then we're going to have Josephine Glaser, Dr. Josephine Glaser. She's also on the board of EPC-USA. And then Betty Odello, a retired nursing professional and president of the Scholl Institute. And I'm going to jump right into it and let Alex get this going. Good morning.
So in the room, we have a audience here as well as online, and I'm very thankful you've joined us. I know that if you're coming to us from California, this is very early in the morning. Morning comes quickly for all of us, especially since it's just short days for us now. But anyway, so I'm going to start it with talking a basic overview. A lot of this has to do with the US, some has to do with Canada. I will give you a key from the beginning. When we're fighting assisted suicide, I think the most effective thing to do is tell the stories. The other side does that to us incredibly well. They come out with the saddest stories to tell us, and they want us to believe that the only option then is to legalize assisted suicide in order to deal with these very sad stories. Well, I think also at the same time, there are stories on this other side of the issue. I think it's very important to understand that in the US, 10 jurisdictions have legalized assisted suicide, and Montana has assisted suicide through a court case. So in Montana, the Baxter court decision created what they called a defensive consent. But that means that the majority by far of the US does not have legal assisted suicide. Now, it is sad, of course, that California had legalized assisted suicide because it represents such a large population. Nonetheless, the assisted suicide lobby is working to expand. And I think we have to be very aware what they're trying to do, what their goals are for expansion, okay? So the assisted suicide lobby, their goals for expansion obviously are to legalize assisted suicide in more states. So we're here in Michigan right now because we know that Michigan is a state that they want to legalize assisted suicide in. That's a goal of the assisted suicide lobby. So Michigan needs to be ready and aware and fighting that in an effective manner. Where assisted suicide is legal, though, they're expanding the laws. And I think this is effective for us to talk about these things because of the fact that, you know, the other side is going to try and sell you, oh, well, we can have a little bit of assisted suicide for there's very few hard cases. That's what they're going to try and sell it in order to legalize it. And then, of course, once it's legal, they try and expand it. That's their game plan. So where does legal, what are they trying to do? They're eliminating the waiting periods. So originally in Oregon and all these states, they always had a 15-day waiting period. In Oregon, that was the first state that got rid of it. Now in these other states, one after one, they're getting rid of the waiting periods. So their goal is to be able to have a same-day death. So your bad day becomes your last day. They're trying to expand who can do assisted suicide. So you're seeing, for instance, the New Mexico law, but you saw recently changes in other states where they're now allowing nurse practitioners, nurses, doctors' assistants to be doing it. Now, the reason for that is that one of the difficulties that the assisted suicide lobby has is they have too few doctors willing to do assisted suicide. So that's a bit of a problem for them. So if you expand the list of who are able to kill, then obviously speaking, you will have more availability. They're also eliminating the residency requirements. So I'll go into that in a minute. That obviously allows out-of-state people to die by assisted suicide. And they're pushing for euthanasia. let's be honest, that's what they actually want. If you read the stuff from Compassionate Choices, they really loud what's going on in Canada. They're really thinking that that is the goal, to have euthanasia, and I'll go into that in a second with you. They've been launching court cases to challenge restrictions to assisted suicide. So some states that have laws that protect people from assisted suicide, they've been having court cases against that to try and strike it down. They've been completely unsuccessful. But also in order to get the residency requirement, I'm going to go into that in a second. They're trying to permit assisted suicide by telehealth, because if they can enable approval by telehealth, that means the doctor doesn't have to ever have a visit with that person. It can be done, the telehealth approval can be done with someone who lives, let's say, in a remote region. So let's say someone in Hawaii, because there's some, just so you know, Hawaii legalizes assisted suicide, but the assisted suicide lobby is always saying, well, there's some islands in Hawaii where there's nobody willing to participate in assisted suicide. So in order to expand access, they want assisted suicide by telehealth. And it's not only for that, but anyway, they're trying to change the definition of what is a terminal condition. So certain chronic conditions are being redefined as terminal to expand who can die by assisted suicide. And they're also establishing now these regional assisted suicide centers. So for instance, in Oregon, where they got rid of the residency requirement, a doctor has set up an assisted suicide clinic so anybody can go there and die by assisted suicide. So let's be very straight about this. The existing approval and reporting system in all states that have legalized assisted suicide does not provide effective oversight of the law at all. How it is it's all done by a self-reporting system. So the doctor who approves your death is the same doctor who can prescribe your lethal drugs, is the same doctor who's required by the law to report the death. So when they say that there isn't anything to be concerned about in state A, B, or C, well, it's very difficult to prove, how would you say, things that are untoward in the law when in fact you have a self-reporting system, meaning you don't self-report abuse of the law. So a couple of you just came into the room, so you might have been a little bit late. If you were speeding down the highway to get here because you knew your time was tight, did you call the state police because you were breaking the law? Probably not. So I'm going to go through the California data with you very quick. My wife always tells me, don't talk about the data, it's boring. And she's right, data is boring. One death is a tragedy, 853. Well, that's a statistic, right? Sadly. But in California, the assisted suicide deaths went up by 63% last year. I think it's important to note that, because the fact is that, when they're going to legalize, they're going to try legalizing in Michigan, they're going to say to you, oh, it's only going to be those very few cases, But, once it becomes accepted, as I already said, they try and then change the law. Once it's become normalized or it's being normalized, they try and change the law to expand it. But on top of it, once it starts being normalized, more people start dying by assisted suicide, more doctors are willing to do it, etc. In 2022, the ingestion status was unknown in 294 deaths. This is an important thing that you have to be pointing out to legislators. When you look at the data, it doesn't actually tell you how many people died by assisted suicide. It tells you how many reports were received. So in 294 of the deaths, meaning these are people who died by, who received lethal drugs, they were prescribed them, they received them, they did die, but they don't know how they died. So if you look at the Oregon data, you see the same thing. Last year in Oregon, there was 101 deaths of unknown. They don't know how the person died. So they know they received the drugs, they were prescribed, they received them. They know they died, they just don't know how they died. Now, these could be natural deaths. Could be 294 natural deaths, or they could be 294 assisted suicide deaths, or they could be a combination of both. What they're saying is we don't have a report. We don't know how they died. That shouldn't make you feel very comfortable if you're talking about giving somebody lethal drugs, okay? And then having them, then they died, you have a death certificate, you just have no idea. No report was received. You just don't know, okay? Of those who reportedly died by assisted suicide in California, this is an important stat. And it's important because it actually hurts us in one way, but it helps us in reality. 89% of the people who died in last year in California by assisted suicide, where the reports came in, that is, were white. Why is that important? 35% of the California population is white. So when we're talking about vulnerable people, we have to understand sometimes we define that incorrectly. And we had the same problem in Canada. We always talk about vulnerable people. We would talk about the frail elderly, people who are with disabilities, etc. And yes, at times those people become very vulnerable because of their life condition. But the reality is the people who want assisted suicide tend to be the white, the wealthy, and the worried. It's just a fact. And that means they're imposing. So when somebody like Anita Cameron from Not Dead Yet calls this white privilege, she's absolutely correct, actually. She's right on the money on that. This is about white privilege. Now, we can talk about vulnerability in a different sense. I'm going to get to that at the end of the talk. Oregon Governor Kate Brown in July 2019, that was the first state where they started expanding. So in 2019, SB 0579 removed the 15-day waiting period. So what it says is they first reduced it, but then they said a doctor can waive the 15-day waiting period. So in 2022, 109 of the 278 reported assisted deaths. Now remember, I say reported on purpose. 109 of those deaths, they had waived the 15-day waiting period. So those people might have died within 24 hours, 48 hours of requesting it, or some of them maybe 10 days. Vermont passed the assisted suicide expansion bill, and this was last year, and they defined assisted suicide as a healthcare service. I think you have to be very careful with this. When you call it healthcare, remember, you have a type of a right to healthcare, right? You have, if you call it a healthcare service, then there's also questions of equality. How can you deny a healthcare service to a 17-year-old when it's available to an 18-year-old, right? So they're going to tell you, oh, we're going to limit this to adults. Well, in Canada right now, they're talking about minors having euthanasia. That's the new topic, right? We've already passed mental illness. So if we can kill the mentally ill, why can't we kill the minors, right, in Canada? If assisted suicide is a healthcare service, then discrimination, you can't deny it to people who are chronically ill. How can you do that? How can you deny it to children? How can you deny it to the mentally ill if it's called a healthcare service, right? And they know that. They know that language is everything, and you have to watch out for these things. And in Vermont, they also passed assisted suicide by telehealth, so they never have to examine you. You can then do the report over Zoom with the physician. You're just receiving the lethal drugs and dying. So there was the case in Oregon, and this deals with the residency requirements. So the Gideon versus Brown case, Gideon is the doctor who actually now runs the assisted suicide clinic in Oregon. Sadly, what this case did is it challenged the constitutionality of the law, because the law said you had to be a resident of Oregon. Well, if you're going to call it a healthcare service, how can you deny it to non-Oregon residents, was the argument. Is unconstitutional. And that, in a sense, that makes sense if you're going to call it a healthcare service, because let's say there is let's say in Oregon, you might have some famous surgeon who's known for doing a surgery on XYZ and is famous for this. That means out-of-state residents would be going to that physician for treatment, and that would be considered, of course, totally normal and acceptable. Well, assisted suicide, you had to be an Oregon resident. So they challenged the law. Instead of the state of Oregon actually meeting the case and fighting to say, no, you have to be an Oregon resident. In fact, what the Oregon government instead did is they just dropped the residency requirement. So now you have suicide tourism in Oregon. So that actually opened the door, of course, to assisted suicide across America. So sadly, at this moment, it's always been seen as a state issue, but people in Michigan who want to go to Oregon can now die by assisted suicide. It's just the reality of how it works, but it's not only Oregon. But also the other great concern is, of course, Vermont has assisted suicide by telehealth. And I've been told by the Oregon physicians that they're also doing that in Oregon. So you could have a situation in the near future where someone is approved for assisted suicide by remote and then flies to Oregon to die. On August 26, a Connecticut woman, so it's the same thing. So in August 26, 2022, a Connecticut woman and a New York doctor challenged the Vermont assisted suicide law, saying that the residency requirement is unconstitutional. Once again, Vermont did not actually meet that challenge. Instead, they just dropped the residency requirement. So as it's already talked about, Vermont has assisted suicide by telehealth. They dropped the residency requirement. And now you have a case on August 29, 2023, that the Compassionate Choices launched to challenge the New Jersey law. Now, this is very interesting because if you've been following this issue at all, you've been noticing that New York every year has an assisted suicide bill. And so therefore, the assisted suicide lobby has not been successful in New York. For whatever reason, it's always been held back, okay? But if they can remove the residency requirement of the New Jersey law, which is what they're trying to do, then obviously speaking, people in New York will go to New Jersey to die by assisted suicide. They're literally neighbors, right? It depends. If you're in northern New York, it's a little bit of a distance, but I mean, where the bulk of the population in New York is, it's not far from New Jersey. So similar to Oregon and Vermont, the case claimed that assisted suicide is a form of medical treatment, and medical treatment cannot be limited based on the patient's residence. So here you get this whole thing going on where the assisted suicide lobby, just so you know right off the bat, they have failed in 2022 to pass any new state laws. They failed. They've so far failed in 2023. You may say, oh, well, what's the point? They fit millions of dollars into 2022 when they failed. Okay, they put millions of dollars into 2023 so far. Now, right now, there's a bill being debated in Massachusetts. I know that Meghan was on yesterday testifying in Massachusetts. But the point of it is that so far they failed. But by changing the laws that are already legal, they're obviously expanding the number of assisted suicide deaths. The good news is that the United Spinal Association, Not Dead Yet, Institute for Patients' Rights, Communities Actively Living Independent and Free, and a few plaintiffs, Lonnie Van Hook and Ingrid Tischer, they launched a lawsuit in California challenging the constitutionality of the assisted suicide law in California. It's essentially based, but not only based, on the Americans with Disabilities Act. Now, I have done a full presentation on that recently, but that's not what we're here for me to do today. But the case essentially asserts that assisted suicide is a discriminatory scheme which creates a two-tiered medical system in which people who are suicidal receive different treatment responses by their physicians based on whether the physician deems the person to have a terminal disease. There's a lot more to it than that, but I'm hoping, very much hoping, that this becomes a very successful case, because it would then lead to striking down assisted suicide in America based on the Americans with Disabilities Act. On March 14th last year, Colorado Sun published an article about Dr. Jennifer Guardiani. I probably pronounced that wrong. I'm not from Colorado. She's an assisted suicide doctor who had approved at least 3 assisted suicides for people with anorexia. Now, this is significant because this is, again, an example of redefining chronic conditions to be terminal conditions, because the Oregon law, the Colorado law, like Oregon, requires you to have a terminal condition that within 6 months you would possibly be dying, right? So therefore, if you've redefined anorexia, then you can then do assisted suicide. We also know that in 2021, or the Oregon Assisted Suicide Report also listed anorexia, so we know at least 1 person died by assisted suicide with anorexia there. So they're redefining what is terminal. And this is not the only situation of redefining. When you go to the reports, you see other conditions listed, okay? So for instance, diabetes. People have died by assisted suicide because of diabetes, and others. The lethal drug trials. I think this is a big topic. Not a lot of people talk about it. Now, these lethal drug trials have really sort of slowed down now because they have found a combination of drugs that are pretty effective at killing and a little bit quicker. But anyway, so what happened is in 2015 or so, the assisted suicide lobby started trying to find cheaper ways to do assisted suicide. So the assisted suicide doctors got together, they discussed certain drug regimens that they knew would kill you. And so they thought, well, why don't we try this? And that's exactly how it was. They sat together as a group of people and they thought this would be a very effective way. And these are drugs that are available to us. So it's like an off listing, right? This is not what it's listed for, but we're going to use it to kill you. Okay. And so the first second-all alternative, so this Seattle Times reported in March 2017, the first second-all alternative turned out to be too harsh, burning patients' mouths and throats, causing some to scream in pain. Obviously not a death with dignity, is it? The second drug mix, so that they did that for a while and they realized, no, that's not working the way we want it to. Yes, it did cause deaths. Anyway, the second drug mix led to these long stretch of deaths up to 31 hours. Well, we know that the longest death in Oregon was 104 hours. We also know that there's been several people who received the lethal drugs, took the lethal drugs, and didn't die. Now, I've got no problem with them not dying, but the fact of it is that means the drugs really were not working as the assisted suicide lobby wants you to think. Now, why is this important? Well, I'm going to get into that for 2 reasons. But the first reason is most people want an assisted suicide because they're in fear of a bad death, right? They don't want to die in pain and suffering. And they want a quick and easy. So, that's how it's being sold. That's the flag they wave. This is simple. It's easy. It's quick. you know, and it's done, and you don't have to worry about a bad death. That's how they, because they emphasize that painful death. That's what they say over and over again, right? An article published in the Atlantic in January 2019 stated an advocacy organization called End of Life Washington briefly advised prescribing a drug mixture with the sedative chlorohydrate to about 70 patients. So Robert Wood was their medical director for End of Life Washington. Now, why does an assisted suicide group need a medical director? I'm not sure. I'm not sure why they need one. But anyway, he said to the Atlantic, we know this is going to put you to sleep, and we're pretty sure it's going to kill you. Okay. In a few cases, the chlorohydrate burned people's throats, causing severe pain just at the time they expected relief. It was actually more than a few cases. The point of it is they were playing with drug mixtures, okay? Medical Express reported on September 8th, 2020, a little known secret not publicized by advocates of aid in dying was that while most deaths were speedy, others were very slow. Some patients lingered for 6 to 9 hours, a few more than 3 days, while a couple more than that. Anyway, assisted suicide is clearly not what it appears to be. There's a whole other thing about this that I think people forget about, and that's the ethics of medical experimentation. So let me say, I'm not going to get into the World War II, but what I will get into is the Nuremberg ethics. And Nuremberg ethics absolutely forbid experimenting on human beings this way. The second issue is consent. It is one thing that someone has consented to have their life ended. It's another thing that they actually consent to be part of human experimentation. They're two different issues, actually. Nuremberg ethics clearly would say this was wrong. You cannot do this, but that's what they did. It's not like they set up, how would you say, experiments with little rabbits first. I'm not suggesting we should be killing little rabbits this way either, but you know what I'm getting to. It's not like they did that. They did human experimentation. And you can actually look at the data because you look at the Oregon report, it'll show you how many people died with this drug mixture, how many died with that drug mixture. And you see over the years how it was changing because they were doing experiments with that to see what was the most effective way and the cheapest way to kill you. Canada legalized euthanasia in June of 2016. Now, what's important about that also is California legalized assisted suicide in June of 2016. Our timing was exactly the same. Less than 5 years after legalizing, Canada eliminated the terminal illness requirement. Now, it wasn't really a terminal illness requirement. It had that effect, but it didn't. The law actually said that your natural death had to be reasonably foreseeable. That's how they would determine if you could be killed by lethal drugs or not. Now, when I'm talking about euthanasia, I should explain the difference. Assisted suicide is when the doctor agrees that your life is not worth living and prescribes you a lethal drug cocktail, but you have to take it yourself. Now, whether you took it yourself or not is a whole other issue because I've already explained how the system works. If someone actually had you or made you take that, they would never know the difference. It's not like there's a third party ever involved with this. There's no overseeing agent here, okay? With euthanasia, the doctor actually injects you, okay? So one is assisting a suicide and the other one is homicide. Now, both of them have the same effect. The intention is the same. The intention is to cause death. The end result is the same, a dead person. The drugs are actually pretty much the same. The difference, of course, is how it's carried out. One is carried out by self-ingesting, technically, and the other one's carried out by lethal injection. Lethal injection is what they want because it's cleaner, simpler, and easier. Anyway, Bill C-7, what did it do? It eliminated the 10-day waiting period in our law. It eliminated that language that your natural death had to be reasonably foreseeable. It allowed for someone who had been previously approved but not competent to die by euthanasia, and it also approved euthanasia for mental illness alone. So you might have noticed the debates going on in Canada. I don't know, you're in Michigan, you might have noticed it because a private member's bill was presented to try and remove that from the law, the mental illness alone, and it just failed by 167 to 150 in Parliament. Basically, almost all the Liberals voted to keep the law the way it is. So as of March of 2024, euthanasia for mental illness alone will be in place in Canada. The Canadian government is now discussing child euthanasia and euthanasia by advance directive or advanced consent. Advanced consent means that I'm right now 55 years old, so I would fill out a legal agreement saying that if I were in such a health condition, please kill me. You have my consent to that. and they could go ahead and do that. Now, obviously speaking, the whole question now of consent really changes, doesn't it, when you do that? Because it's not about me asking. I'm not saying this, that we should allow euthanasia by consent. What I'm saying is you can see how now the whole concept of consent changes, right? When you do it by advance consent. Alan Nichols. Now I'm going to tell you some stories in Canada. I think the Canadian stories are powerful, especially since you're just literally next door to Canada. The other thing it's powerful is, remember this summer how in Canada we had all these major fires going on and the smoke was affecting Michigan. You guys remember that? Yeah. Well, that's what's happening with euthanasia, whether you like it or not. The smoke from our euthanasia law is affecting Michigan. People have relatives, people know people. There's a lot of interconnection, whether you or I like it or not, there is. Okay, we are affecting each other. The Alan Nichols story is important because he died by euthanasia in August of 2019. He was only depressed. Okay, Alan Nichols had gone through chronic depression almost all of his life. He was a person you could say has a disability, but he had been gainfully employed all his life. So this wasn't an issue of poverty. This was an issue of a man who would go into deep depression at several times in his life. He went through this where he had to go to a psychiatric ward to prevent him from causing his death. So he was going through suicidal ideation. What made August 2019 a little different was that he asked to die, and they took that as a request for medical aid in dying. We call it medical aid in dying in Canada just to make you feel better about killing. He was approved for medical aid in dying. His family begged the doctors to reassess him. They said, you know, Alan's gone through this so many times before. Now, why is this so important? We hadn't legalized euthanasia for mental illness yet. So the doctor actually lied on the death certificate in order to justify what the doctor had done. Because Alan wasn't sick. He had no illness. Joanne Cowie has multiple disabilities. She actually lives in Windsor, Ontario. She's on your border. If her wheelchair got moving, she could be in Michigan in no time. And she lives with her daughter. Joanne says that when her daughter finishes school, she will die by maid. Joanne says that she does not want to die by euthanasia, but she's living in poverty and she can't continue to live on $50 a month. So it's the reality of a person with a disability. She actually has multiple disabilities. She's not able, she has worked in the past. So she talks about the fact that she has several university degrees. She's had been gainfully employed for many years, but because of her current state of disability, she's unable to work. And on the disability benefit, after she pays her rent and her expenses, she's got about $50 a month to live. And she says that's not enough to live, that she can't continue this way. After her daughter finishes school, she wants to die of euthanasia. But you see, euthanasia for poverty seems like a ridiculous concept. Now, I'll tell you right off the bat, the other side is going to tell you Schadenberg's lying to you. He lies. That's what they're going to say. They're going to say you can't have euthanasia for poverty in Canada. Well, technically, they're correct. You can't. But you see, Joanne knows that she'll be approved for euthanasia based on her disabilities. Because when we got rid of the part of the law that said that your natural death had to be reasonably foreseeable, what remained in the law was that you needed to have an irremediable medical condition, right? Because if you remove one of the requirements, then what's left? You had to have an irremediable medical condition. Well, people with disabilities tend to have an irremediable medical condition. That's why they're qualifying, okay? Meghan Nicol, who operates the Mississauga Food Bank. Mississauga is right near Toronto. In November 22, Meghan told Maclean's magazine, which is a sort of a national sort of magazine, that some of the food bank clients were asking for euthanasia in response to the grind of living in poverty. Now, you notice this is also just post-COVID. Post-COVID, there was a lot of issues going on, but she's talking about people who are poor, who are asking for euthanasia. They're going to their doctors requesting euthanasia, and they might have disabilities. They might have other health issues that are going on, and that's what they would be approved for, but it's actually the poverty is why they're asking for it. Amir Farsu is a man, he actually lives in St. Catharines, Ontario. He's a man with disabilities who was told that he needed to move out of his apartment because the owner wanted to renovate the building. Okay. But you see, he's on a disability benefit, so he's got a very limited income. And so he was trying to find a place to live, but there was no place he could find that he could afford to live. So his disability benefit did not cover enough money to pay rent in St. Catharines. So he said, I would rather die than be homeless. So Amir was approved for euthanasia based on his disability because he could not find a place to live was actually the reason he wanted to die, not because he actually wanted to die. A GoFundMe campaign raised enough money to find Amir a place to live. He's actually living in the same building, funny enough, because they raised enough money. He was able to take over a different apartment as they renovate the one apartment. I guess he's going to move around a little bit. Rose Finley is a woman with quadriplegia. She's actually worked all of her life. She had an accident when she was 17. So she's has quadriplegia, but she's written books. She's done different things. She's been very successful all of her life. But then last year she became quite sick and she found herself unable to work. So she applied for disability benefits. Now, normally speaking, someone with quadriplegia would have disability benefits, right? But she never applied for it because she never was in a situation. She's a married woman. She applied for disability benefits. She was told it would take her 6 to 8 months to get approved for disability benefits. She applied for MAID, was approved, and she was told that she had to have a 90-day waiting period. So in Canada, how it works is that if you are deemed to be terminally ill, there's no waiting period. You can have a same-day death. Same as what they're doing in Oregon now, where they got rid of the waiting periods. So if you're deemed to be terminally ill, you can have a same-day death. But if you are not dying, meaning you have a chronic condition, etc., such as Rose, she's not dying, you'd have to have a 90-day waiting period. So it would take her 6 to 8 months to get disability benefits, which would not have covered her expenses anyway, or a 90-day waiting period to die. Madeline has a rare medical condition. Now, I see Madeline's mother was one of our supporters. So I knew about Madeline before this ever hit the newspapers. Her first newspaper article came out, I believe, in November of 2021. She was featured in several other articles in 22. And she's got a rare medical condition. She's unable to get coverage for her treatment in Canada. She can get treatment in the US, just so you know. So when we talk about the beautiful Canadian medical system, which covers everybody and you can have free medical care in Canada, etc., that assumes that you can get it. It assumes that you can get it. It assumes, and we're not even talking about the Canadian waiting lines now, but nonetheless, Madeline told Châtelet magazine that when she is so far in debt that she cannot pay for her treatment by credit card, because she was paying for how would you say, to receive treatment. So she was ordering certain things and it was being sent to her, whether I'm not sure exactly if it was Amazon or what it was that she was ordering it through. Then she would be seeking euthanasia to die by euthanasia, not because she wants to die, but she says, I can't get treatment. I can't get treatment. My only option will be to die. She's still alive. I'm hoping that that never comes to the day where she says that she's better off dead. This is this veteran stories. We had a Canadian veteran who was living with PTSD. I'm assuming you've got lots of American veterans with PTSD. He contacted Veterans Affairs seeking help. The Veterans Affairs employee asked him if he had considered euthanasia, if he considered MAID, medical aid in dying. The PTSD was the issue for this person. They wasn't seeking death, but he's being, and then he was told by the Veterans Affairs employee that, well, you know, several people have called us with this and they've chosen euthanasia. So when this came out, our Veterans Affairs minister, the government minister, said this was a bad one-off. It's a bad case. Someone just, you know, a rogue employee, okay? And by saying that, well, that's when these other cases came up. So then we learned that there had been at least 6 of them minimally. There might have been more. At least 2 of them had died by euthanasia. And then the case of Christine Gauthier came out. Now, Christine Gauthier is a veteran who became disabled while she was a veteran while serving our country. She then became a Paralympian. She won a bunch of awards for our country. Anyway, Christine contacted Veterans Affairs because she was seeking help to purchase a wheelchair lift. Now, does that seem unreasonable? You've become disabled as a veteran. So you're a veteran who became disabled in service of your country. You're asking for help to purchase a wheelchair lift and install a wheelchair lift. And she was told, madam, if you're really so desperate, we can give you medical aid in dying, medical assistance in dying. It shows you the attitude, the shift, the concept, the attitude. Why are these stories so important? Well, because the culture shifts when you legalize killing. You can't say that, oh, well, you know, that won't happen in Michigan. We were told in Canada, when they were debating euthanasia, we were told, you know, the Dutch and the Belgium stories, yeah, there's some bad stories here. Yeah, there were some bad things that happened there. But Canada is not the Netherlands and we're not Belgium. That's what we were told. Don't worry about it. It's not going to happen here. It's not going to happen here. Kathleen Mentler, well, in June of 2023, she was experiencing suicidal ideation and she had enough understanding to know that she needed to get help. So she went to the Vancouver General Hospital for help. The counselor told Catherine that she could not get an appointment for her mental health to see a specialist until November. Now, we have a real big backlog in Canada. It's called universal health care, where you don't have enough psychiatric care. You don't have enough, mental health care in place, but you've got people needing it and they can't buy it on their own. So they have to wait in line. So no, she was told November, but then the counselor asked her if she had considered medical assistance in dying, medical assisted suicide. Now, you would say, once again, is this a rogue employee? Well, in fact, the counselor, if you read the story, and I can send the story to you, I actually have it in my little pamphlet there. The counselor told her, I felt such relief when another woman came to me a few months ago and same sort of situation. And then I heard she had died by drowning. And I'm thinking, this is a woman who's come to your hospital because she's experiencing suicidal ideation. She wants help. You're telling her there's no bed available and there's no way she can see a specialist until November, but you should be considering medical assistance to dying. Canada will begin to permit euthanasia for mental illness in March of 2024. Now, we got to understand the current situation is that the government has agreed that we're not going to change the rules for it. We're just going to make the eligibility for people with mental issues alone. So therefore, currently, people with mental health issues are dying by euthanasia, but they need to also have a physical issue at the same time. Okay, so let's say you had multiple sclerosis and it was a significant condition. So therefore, you are seen as having a chronic condition, you're approved, but you might also be going through deep mental health issues, and that would be a mitigating factor. But in March of 2024, the government at this moment is saying that the 90-day waiting period is the only thing that would be in place because these people aren't terminally ill. Now, what makes it even worse is there's been quite a few stories now of people who are going through significant mental health issues who then say, well, if you don't give me euthanasia, medical aid in dying, I'm going to die by suicide. So because they become suicidal, then there's sometimes some of these doctors are deeming them as being terminally ill, then they can have a same-day death. Remember, language is everything, right? It's not incidental. It's the whole thing. The language is everything. The other thing is, we can't, most physicians wouldn't do that. That's correct. There are some physicians who do euthanasia who will only do one or two ever because they believe in it, but they're very careful with it. And then there's others who are running clinics. Like there's the MAID clinic in Toronto. There's two clinics. There's one in Vancouver, one in Victoria. I'm assuming there's others out there. I just don't know about them. Fighting assisted suicide. No, I don't have my clock in front of me. Okay, I'm actually doing just fine. This is good news. We need to call it what it is. So the other side is going to do their best to redefine the language. So they're going to call it medical aid in dying, physician-assisted death, all this kind of stuff. These terms don't help us. We need to call it what it is. It is assisting a suicide. It's properly defined as assisting a suicide. I'm assuming that they contravene your manslaughter laws here in Michigan. I haven't actually looked at it. Is that correct? Is that how it works in Michigan? Or do you have an assisted suicide act in Michigan? You probably have an assisted suicide. Yeah. That's good. Excellent. We oppose assisted suicide. Why? Because these laws allow one person, usually a physician, but often in some states it's nurses. Canada is nurse practitioners. As I say, New Mexico allows physician assistants, nurses, etc. Not chiropractors yet. I know I shouldn't joke. That's not nice. But anyway, to be directly involved with causing another person's death. Creating exceptions to homicide or manslaughter or things like this, they're just bad ideas. I can't understand why people don't understand that how this could go so terribly wrong, giving somebody else the right in law to kill you. And it is about killing you. The term aid in dying is also used for both euthanasia and assisted suicide. So you're going to find them using the term aid in dying or medical aid in dying. And you have to know right off the bat that their goal, long-term goal is euthanasia. So if you use the term that's part of both, then obviously speaking, in the future when they get euthanasia, it'll be easier for them. The assisted suicide lobby sells this as an autonomous act, my body, my choice. This is a lie, okay? It's not an autonomous act because somebody else is directly involved in the act. The my body, my choice, you've probably never heard before, but it is the term they like to use. Clearly, assisted suicide is not an autonomous act. Euthanasia is even less of an autonomous act. When somebody lethally injects you, how can you assume that was an autonomous act? Think about it. Somebody is injecting you with lethal drugs into your bloodstream. Many people requesting assisted suicide have issues related to capacity. These people are often experiencing hopelessness, despair, alienation, cognitive distortions. Assisted suicide is about abandonment, not autonomy. Autonomy, they want to call it autonomy because we all want autonomy. We all want freedom. We all want choice. All of us do. We're human, right? We must work with people from all political points of view because there's no silver bullet on this issue. You have to think politically speaking. Your internet connection is unstable. Maybe. You guys still hear me fine? Okay, good. You're going to hear from Peter Wolfgang. They have faced an assisted suicide bill 11 years straight in Connecticut. And they have been able to hold it off 11 years straight in Connecticut. Connecticut is a Democrat state. So it's important to understand that there's no silver bullet to this. There's some people who are going to be natural allies to you in different ways. Okay. People with disabilities have personal experience that needs to be heard by politicians. I think that the fundamental issue of people with disabilities, of course, is the lived experience. The stories are more important than any other philosophical thing. The other side is selling the philosophy of freedom. We must talk about actual people. We must focus on people. They're going to do the same thing with their sad stories, though. They're going to have, and there are sad stories. So let's, I'm not minimizing that, but is the answer to kill these people? The answer is no, we don't kill people. We encourage people to work together, but never discourage people from working on their own. Why am I saying this? There's no silver bullet on this. So yes, as a coalition, you want to have a direct point of view. You want to speak certain talking points. You want to be focused. Absolutely. But that doesn't mean that the person, there's a group, for instance, in Connecticut, they call themselves, what are they? They're progressives against assisted suicide, and they're unwilling to work with anybody. Okay. They are literally, Megan's laughing, but it's true. They are unwilling to work with anybody, but they have been effective at moving certain votes. So why would we tell them, oh, well, we work as a team? They're not going to work with you as a team. So that's fine. Okay. We do exactly what we're going to do. You be focused, etc. But don't be telling others that you can't be doing, trying to stop this. I don't know the effect they're going to have. I don't know. Talk about the lethal drug experiments. I can send you all those articles. Why? I think this was, I think it's completely wrong to kill people, but I think it was totally unethical, just the basic premise of what they were doing. And yet everyone's like, and I'm thinking, oh, come on, death by lethal drugs may not be dignified, may not be quick, may not be peaceful. Why is that important? Because that's what they're selling. Quick, peaceful, dignified deaths. That's what they're all about. It's all a lie. The lethal drug experiments on people were unethical and caused people to suffer. And as I said, they had consent to prescribe lethal drugs, but they may not have had consent for human experimentation. On top of that, Nuremberg ethics. You notice there's been a discussion by a lot of people now about this whole question because it wasn't that long ago that Nuremberg ethics ruled. And now if you start reading medical journals and you start looking through the lines, you start realizing, I think it's past. I think people are now ignoring it. Not to say it isn't important. It's very important. Those ethics were created. Why? To make sure that we didn't repeat the same crimes again, right? But on we go. We're told that people ask for assisted suicide because of pain and physical suffering. There are some cases like that, absolutely. But the data suggests that very few people actually ask for it for these reasons. We have, and there are radical autonomists out there. These are the people who say, I want to die on my birthday. They get approved for assisted suicide. They're going to throw their party. They're going to be like that. And there's going to be a group of them like that. And the more common assisted suicide becomes, the fewer of those deaths become seen as the norm. But most people don't actually ask for assisted suicide for that reason at all. Most people are going through a difficult time in their life. They have physical or psychological conditions. They're feeling lonely, depressed. They fear for their future. They've lost meaning, hope, purpose, value. They feel their life has no meaning. They feel that there's, and if you question me, I say, well, I'm assuming not everybody is in that boat, but in my experience, almost everybody is in that situation. We have a helpline. We've dealt with a huge number of people who have been approved for euthanasia. And when you drill down on the issue and you ask them, well, why do you actually want the doctor to do this to you? Why do you actually want the doctor to kill you? The answer almost always is, I have nobody in my life. Or I can't see any more purpose to my life. I don't know why I'm living. These kind of things. Well, those are social questions. Those are the signs of our cultural breakdown, right? Those are the signs of family breakdown. Those are the signs that there's a lot of loneliness in our culture. And we know there's a lot of loneliness in our culture. That's what it's showing you. And actually, sadly, it's true. But do you kill people for that? The culture of abandonment that leads to assisted suicide can be changed. We need to be really focused on caring for others. I do think it's essential. I think it's essential that people feel that their life lacks value, hope, meaning, have someone who cares for them and offers them purpose, support, genuine hope from a significant community. The answer is to care and to be with others, to journey with others through their difficult times in their life. I always say to people, I cannot change the world necessarily, but I can change the world around me. And that's what we need to do in the long term. The short term is we need to make sure they don't legalize assisted suicide. Assisted suicide is a serious issue in the sense how it changes the culture, it changes the thinking, it changes the idea of how we die and what we do to kill people. It totally changes the whole concept, and it means that we dehumanize our population, right? We dehumanize our population. And so basically, I think my presentation has come to an end.
Right. Thank you so much, Alex. My gosh. I mean, he gave us such a great understanding and even a better understanding of what's going on. I want to introduce now Mr. Edward Rivet. He's Advocates for Better Care Michigan, and he's going to go over the history of assisted suicide in Michigan. Thank you. Oh, I'm sorry. And also with Mr. Rivet is Genevieve Marnon, the Senior Policy Analyst and Advocate for Better Care Michigan. You're welcome.
Okay, Jen and I are just going to roll one into the other. So I'm going to begin by doing a little commercial for Advocates for Better Care. You see our banner there in the back of the room. It is a project, a committee of Right to Life of Michigan. We formed it back in the bad old days of Kevorkian and so forth to address specifically the issues that Alex just overviewed, not only the challenges that euthanasia and assisted suicide present, but just culturally as a whole and end of life issues and those things. And that's really the role that I'm going to have here today. Because like, why do we want to rehash the history in Michigan? It would just seem like, why would we need to do that? But what I hope to do is help you understand the environment we've been in really for several decades now, a couple, 3 decades, because of what happened, the work that we did, and the degree to which we have a unique platform in the state of Michigan for what Jen will explain after me, what's coming, what the pro-euthanasia folks are trying to bring to Michigan. So it's sort of that, laying that context will help folks understand where we're starting from. I guess that's the point of what I'm doing. And I have to say, since the most dramatic events on these issues for us happened in the 1990s, it took me a little bit of time going back into the annals of things and some history research, even though I lived it all, and many of you in this room lived it all along with me, kind of getting it all in a chronological understanding and so forth was a bit of work to go back and look at it and to really bring forward the important stuff. So the core of our assisted suicide odyssey was really in the 1990s. And I'm going to try and explain that. So we had been involved from really the 70s, the mid 70s and on, in a long battle over living wills in the legislature, legalizing living wills. And we knew that that was the framework, the beginning of how to introduce euthanasia and assisted suicide by distorting end-of-life care issues and letting people make these, advanced directives to say, I want to die if I can't make that choice, et cetera. But it was really that mindset of shifting who in the end is deciding. Because once you're incompetent and you're trying to, someone else is really making the decisions for you, that is the opening of the concept. So we fought living wills in the legislature from 77 right up through till 1990 when the Nancy Cruzan case was decided by the US Supreme Court that kind of set a legal bar that allowed us to put the strongest provisions to protect patients into our advanced directive law. And there's a copy of our advanced directives on our Advocates for Better Care table in the back. And we have, I think we're supposed to have, well, yes, when we have a brochure on that, I probably wrote the first version of that one. We have another brochure on euthanasia. I know I wrote the first draft of that one. They've been modified, doctor prescribed suicide. All of those resources are part of that effort for us to shape the medical ethics of end-of-life care in the legislature. And we fought and we got blamed for a long time that these bills would have passed if it wasn't for right to life in the Catholic Church. Well, we'll take the blame. But the Cruzan case came along and it kind of set the framework. So we were able to pass our power of attorney law. And to this day, now 30 plus years later, it is still the model best advanced directive law or a patient advanced power of attorney law to protect patients probably anywhere in the country. So it was a long battle and we won it. Well, right as that was happening, right as the Cruzan case was being decided by the US Supreme Court, Jack Kevorkian showed up on the scene and killed Janet Atkins, June 4th, 1990, a woman from Oregon who flew here to die in Jack Kevorkian's rusty Volkswagen van at the Waldmark Mountain State Park. It's all coming back to me now in a rush. And this set us on an unbelievable, almost theatrical reality. It was surreal, a surreal reality of what happened in Michigan after Jack Kevorkian killed his first patient, came out proudly announcing, I'm now in the business of helping people kill themselves. And therein, the problem came in the prosecutor in Oakland County, a friend of ours for a long time since, Richard Thompson. He looked at the laws and said, well, what do we do? Well, under Michigan's common law, assisting in a suicide, and common law, of course, is not written on the books. It's how the courts have interpreted prosecutions and cases and so forth over time. Under the common law, assisting in a suicide was a form of murder. But again, because there was no statute, prosecutors in addressing Kevorkian's string of killings, which went on for 8 more years and took 130 lives before he was done, at least that we know about, they had to use charges under the common law without a specific statute. And that made for a difficulty because it also created the opportunity for a certain attorney who stepped into the picture, Jeffrey Feiger, to get in and exploit every legal loophole and challenge. And as Alex said, bring all the sad stories. So as Kevorkian killed one person after another and the charges were brought up, they were also challenging these things in the courts. So we were now on a front where we had a legislative battle, we had court battles, and the whole thing was being played out in the media. So it was a constant public relations battle. For the whole decade of the 90s, we were fighting the rhetorical battles, the legal battles in courts, and the legislative battles. So it was a full-time endeavor dealing with this for all of us, and you'll see. So we immediately introduced legislation to ban assisted suicide because we had this gray area in the law and it was being strung out. It wasn't going to be settled in a couple of months. This was going to take a long time to hold these cases. They were going to go on appeal. They were going to eventually go to the Supreme Court. So this gave Kevorkian, a playground, even though he's being charged. And sometimes the first judge would throw the charges out, then they had to be appealed. And then he'd kill someone in another jurisdiction and we'd try to charge him in that jurisdiction, and on it went. So it was just a circus as he piled up the bodies. At first he did them all in Oakland County, but eventually he started going elsewhere in the state, killing people. He would just dump the bodies off at a hospital emergency room, whatever. It was, like I said, surreal theatrics, and it was unbelievable to live through. So in the course of while all that's going on, the legislature was twiddling its thumbs. We did not have a strong majority in 1992 in the legislature. We were trying to get a ban on assisted suicide, and pro-assisted suicide folks had enough control of committees and so forth in the legislature that we couldn't get that ban moving. Well, what was moving was a bill to create, what else does the government do? Creates a commission to study, right? When it's not going to do the right thing, it creates a commission and studies it. So a bill was moving through that would create the Commission on Death and Dying. And we, of course, were pushing the other avenue. And what happened is, now, all 2 years plus after Kevorkian had started killing people and was still killing people, we got the ban. The commission bill was moving through, and there was enough pressure because the bodies were piling up legislatively that they agreed to put a temporary ban into the bill that created the commission. So as we got to the end of 1992, we had a bill passed that created a temporary ban on assisted suicide, which of course was challenged in court, and it created the Commission on Death and Dying. Here was the problem. That law passed at the end of 1992. We didn't get immediate effect, which meant the law was not going to take effect until the end of March. We had about a 90-day window from the passage, from the end of the year until the law taking effect, where we still didn't have a ban. So what happened? Kevorkian just went on a rage. He was killing 2-3 people a week, dropping their bodies, and it was crazy. It got so bad. I think he killed 8 people in the course of like 10 days. So it put enough pressure on the legislature. There was a little technical detail we wanted to fix in the bill, in the original ban regarding hospice care and so forth. So we were trying to get that technical fix through, and we wanted to use that bill to rush through fast as we could and put the ban in, give it immediate effect. But our suicide opponents were blocking it. They kept blocking it. So we were fighting in January, and the bodies were piling up. We were into February. Finally, 45 days into 90 days, the other side relented because the bodies were piling up. On the same day, we passed the bill through the House, and the Senate concurred, and the governor signed it live on television at 5 o'clock that night. And the day before, I couldn't get a vote on the bill. God just moved, and it was miraculous. And at that point, we had the ban on assisted suicide in effect. Didn't really stop Kevorkian, because now he kept playing legal cat and mouse, and he would get charged in this place or that, and then one judge might throw it out or whatever. It was just crazy, but he continued to kill people even though we had a ban on assisted suicide, because it was all being challenged in court. So this goes on now in 1993 and 1994. The commission, which I served on, comes out with a meaningless report that had every side and every opinion and no consensus on what to do. So that was a big waste of time. And in the course of it, we get through that. And after a couple of years, the ban on assisted suicide expired. But at the same time, all those cases now for 5 years, made it to the Michigan Supreme Court. And in 1995, the Supreme Court ruled that our ban had been properly enacted, because that had been thrown out by earlier judges, which is why Kevorkian kept killing. The ban was actually properly enacted, that the common law was still applicable. You could still charge like we used to charge under common law for murder, and that there was no right to assisted suicide or euthanasia in the Michigan Constitution. Huge, huge victory in 1995. So that's important, knowing that we have the legal precedent of those cases that says there is no right to assisted suicide under the Michigan Constitution. That'll be important in a couple minutes. So now we have all that behind us, but we didn't have a ban anymore. It expired, and Kevorkian was still playing games with all of his challenges and so forth, trying to avoid ever being convicted. So in the meantime, during that, we were also working as advocates for better care and Rights Life of Michigan in the legislature to do tons of education on good end-of-life care. We passed a law to create hospice homes in Michigan. which didn't exist. There was no place for like a homeless person or someone without family to support them to actually get hospice care. It wasn't even allowed. You either had to be in a nursing home or whatever, and the laws didn't allow them to treat you the same way. Hospice homes. We made sure pain management was part of the medical school curriculum in Michigan medical schools. We had the power of attorney law that we made sure was going to be allowing people to be protected. We put all these brochures together. So at the same time that all this craziness was going on, we were also putting forward the alternative and educating and trying to set forth a standard in Michigan that said, we don't need what Jack Kevorkian is selling. We don't need it. We can have good pain management for people. We can have good end of life care. We can have the right kind of documents and so forth. So that was an important track of what we were doing that was changing or shaping, as Alex said, shaping the culture to reject euthanasia and assisted suicide. And that was an important thing. And then at the same time, while we were dealing with this, the pro-euthanasia folks were pushing their court cases all the way to the US Supreme Court. And fortunately, in 1997, a case out of Washington, case out of New York State, Quill and Glucksberg, those two cases were decided together. It was essentially the same case, that there was, like a Roe versus Wade, there was a right to euthanasia and assisted suicide in the US Constitution. So they were trying to score the big win like the abortion advocates did. What's that? Yes, I know they were trying to score the big win, but fortunately, they lost. I was saying they were attempting to get there, but in 1997, those cases came down. And like the Michigan Supreme Court, found no right to assisted suicide or euthanasia in the United States Constitution. So that's an important advantage we have, given what we fought for 50 years as right to life on the abortion issue. You know, we had to fight Roe, but we won these cases. So that platform now said no right to euthanasia or assisted suicide in the federal constitution, the state constitution. We still didn't have a ban though, and we had a variety of prosecutions and cases against Kevorkian. But wherever he thought he could get away with it, he'd kill somebody else. Like I said, he started, 130 people. So along comes Marion's friends, a group of people who rallied around in the memory of one of Jack Kevorkian's victims, Marion Fredericks. He'd killed her. She was from Ann Arbor. A bunch of folks decided, well, if we can't win in the legislature, we can't win in the courts, we're gonna put a proposal on the ballot to legalize assisted suicide. And they did. They collected the signatures. We tried our level best. I'm looking at Amber because back in that day, we were doing everything we could to knock their signatures out, disqualify them from the ballot. We thought we really did it. But the Board of Canvassers turned a blind eye and said they had enough signatures, and they put it on the ballot. Well, right as that was happening, we were just getting the votes finally, and passed a ban on assisted suicide, a permanent ban on assisted suicide in June 98. But we went right from that big victory to having to fight a ballot proposal to legalize assisted suicide. Now, fortunately, the other side had a really badly worded proposal. They were bad spokespersons for their own cause, and they didn't have any money. So we put together this broad coalition that included disability groups. The medical society was with us. We had this huge coalition. And for those of us who were around, now 25 years ago, right now, we had the no on proposal B. B is bad legislation. We can all live it. And we absolutely crushed it on the ballot because we had everything in place, and we won 71-29. So we put that to bed. The only problem was Jack was still on the loose. And there were still cases that were pending on that. So we had almost put everything to bed. As I like to say, there was this monster of euthanasia. We had it down on the ground. I had my foot on its neck, and I was never going to let it up again. But we still had Jack on the loose. So Kevorkian always ratcheted up. I mean, there was the time he killed somebody and literally claimed he cut the kidneys out of this patient victim I should say victim, and made them available for transplant, which of course was absurd on every level. But he always was ratcheting up what he was doing. And so then in 1999, he released a video or provided a video to the TV news magazine, whatever we call 60 Minutes, of him lethally injecting Thomas Yelp. Put it on and they aired it. Obviously, they cut it off at a certain point, but he basically said, look at this. You thought I really ratcheted up. This is me lethally injecting this guy and killing him. Well, that got him prosecuted for good. That was the one that was the last straw. And even advocates of assisted suicide were really glad to get him off the stage. He was convicted of second-degree murder, spent 8 years in prison. He was supposed to serve 10 to 25 years, but he was out in 8 years. Promised to be a good boy. I won't ever kill anybody again. So they let him out. And about 3 or 4 years after that, he passed away. So that was finally the end, but he demonstrated exactly how far they would go with this, right? He just showed, even though we had been dismissed and said, you guys really are all this slippery slope stuff. Kevorkian was demonstrating it one by one by one in his behavior. So we were on the right side. We did the right thing. So when you think about where we are starting from, why has it been quiet on assisted suicide in Michigan for a while? Well, we have a good platform. We got the constitutional decision in our favor. We still have a ban on assisted suicide. We have the best laws on end of life care. And there's been many, many other things we've done to make sure that our end of life care laws are protective of patients and their guardianship laws and so forth. We're constantly fighting to do those things. So we have a mentality that is stronger here in Michigan, perhaps in other places, but that doesn't make the threat any less great. The very things that Alex just outlined are real threats that are coming. And now I'm going to have my successor and colleague, Genevieve, come up and explain kind of where we're at now and what's being proposed and the challenges for the state. So where's your question?
All right, I am like old school and I don't do technology well, so I'm going to try and do paper and this computer thing at the same time. So I know Alex did a great job of kind of defining some of the terms, but I want to go over them a little bit more thoroughly because I think there's a lot here and people get confused because the terminology gets tossed around like crazy. So the term medical aid in dying is the term that is preferred by the assisted suicide organizations because it can encompass everything. What does it mean, medical aid in dying? It can mean euthanasia, which is actively killing somebody without their consent. It can mean assisting someone's suicide with their consent. And it could mean a whole lot of other things in the sense that theoretically, we could even draw this out to mean hospice care, medical aid in dying. We're helping them to have a good death, right? And sometimes we use medicine to do that. So that term is their preferred term, but don't let it confuse you because what they really mean by medical aid in dying is the goal to medically killing people with or without your permission. So that's the other, so I really wanted to point that out. So physician assisted death is one term, physician assisted suicide, assisted death, voluntary euthanasia, that's another term that sometimes is used, death with dignity, physician assisted dying, and a physician assisted suicide. They don't like the word suicide, so we want to keep using it, right? Because no, true story. Because suicide, we know about suicide. We talked about suicide during COVID. Everybody was worried about all the suicide rates going up and suicide rates of victims, our veterans, et cetera, et cetera. So they don't like that term. And really, in a way, it's a misnomer because ultimately, as we see, as Alex pointed out, it goes that slippery slope genuinely through, yes, they wanted it, and then they don't want it, or somebody else is making that decision for them. So I just wanted to be, wanted to be very clear on some of those terminologies because they do get tossed around a lot. So we like to refer to it exactly what it is. It's physician-assisted death. regardless of whether you chose it or not. So that is the difference. What is the difference between euthanasia and assisted death? And again, those lines are being blurred, but I think it's very clear that we look at the terminology and really understand it. Theoretically, euthanasia is when you are lethally injected by a medical professional to ensure your death. You don't take an active role in doing so. So you don't push the button, you don't ingest the pills, somebody else does it for you. And really, I think that is the goal because it's, as Alex pointed out, it's cleaner. They can make sure you're dead. Because if you take the pills at home, maybe you throw them up, maybe you don't die, maybe it takes a long time, maybe it's painful, and those horrible stories get out and they don't want the negative stories. So their goal really is to get to euthanasia, active euthanasia on their part. Assisted death, again, it's a misnomer. What does it mean? We assist people in dying all the time. That's what hospice care and palliative care is all about. We do provide assistance in death, but that's not their terms. So we just want to make sure that we're really clear when we're talking about the different terminology. So what is palliative care? I mentioned it a couple of times now. So let's talk about palliative care. Palliative care is medical care for somebody, even though we know that they are not likely going to recover. They're going to have a long-term illness. They're going to eventually slowly decline, possibly, and then die. Because guess what? We all die. None of us gets out of here alive. So palliative care is designed to help people, and people do sometimes recover even though they're in palliative care, which is different than hospice. Hospice care is designed specifically for someone who has a terminal diagnosis for whom it is likely they will die within the next 6 months. So there are parameters. I know there's always fuzzy lines around there, and people do outlive their hospice diagnosis, and they sometimes have to get back and get it re-diagnosed. But I think some of our doctors later are going to talk about that. And then we hear this term all the time, end of life decision-making, end of life decision-making. And as a general rule, we advocate for people talking about their end of life decision-making, meaning appoint a patient advocate, appoint someone who can make your decisions for you should you become incapacitated. And that's important because, once upon a time, your 26-year-old gets in a car accident, mom and dad show up at the hospital and the doctor talks to you about what's going on. Well, anybody ever hear of HIPAA? HIPAA is the federal law that says you can't disclose people's personal medical information. So as we've seen HIPAA laws become more and more restrictive, we've also seen it being exploited by certain doctors who really feel that the patient should just be dead now. And so they use HIPAA to withhold information from the family members. So going in there with a patient advocate form, you are now legally authorized to get the information about your loved one when they can't speak for themselves. So we do want people to make end-of-life decisions with regard to who their patient advocate will be, what they want or don't want in the way of end-of-life treatment. Do they want palliative care? Do they want hospice care? Do they want to die at home? Would they be more comfortable dying in the hospital where they can have treatment? Those kinds of conversations should happen. The problem that we're seeing is that terminology is getting skewed. So the assisted suicide lobby would like to see assisted suicide as a continuum of care with that end of life decision making. So we want to be really careful when we talk about these terms, what we really mean. So medical aid in dying, physician assisted death. I think I already went over that. I think I doubled that one. Sorry about that. Advanced directives. So we talk about advanced directives all the time. We hear this term thrown around all the time. And I will let you know, in Michigan, we've been very careful in being involved in a lot of the legislation that they've used with regard to advanced directives. So for example, the patient advocate form, in order to designate someone to be your patient advocate. I'm personally working on some guardianship laws right now to make sure that they are protective for the ward. The post form, Michigan MyPost, it's called MyPost, Michigan Physician Order Scope of Treatment. That took 6 years of negotiating and working on it. And I was involved in that because we didn't want it to get derailed and become a living will. I think Ed mentioned something about living wills. And Alex mentioned that part of the goal of the assisted suicide lobby is to have you be able to designate that you want to be euthanized if you get to a certain point in life. Well, I'm standing here as a healthy, I won't tell you how old I am, woman. And if I could see, well, I don't ever want to live like that, right? So when you're young and healthy, you could say, well, I don't ever want to live like that. But I can tell you, my father was bedridden in the last 2 years of his life. And guarantee you, none of us in here ever say, you know what? I think I want to be bedridden when I'm old. None of us. But I can tell you that his adjustment to that, his quality of life, he gleaned as much quality of life out of that as he could. So the idea that we have living wills or that we make a declaration of what we want when we're young and healthy is not patient protective, but it is the goal of the assisted suicide lobby. So living wills are dangerous for that reason. Advanced care planning is great, provided that you don't have a legal mechanism to say when you're 26 or 55 or whatever age that, yes, I want to be euthanized. So those are things that we need to keep in consideration as we move forward. So this is a topic: withholding or withdrawing life-sustaining treatment or unwanted medical treatment. One of the things we've seen over the past 30 years is we've shifted in our culture from a culture that really said the doctors need to do everything they possibly can to keep somebody going. That was sort of the status quo maybe 30, 35 years ago. And we saw a lot of court cases, as Ed mentioned, that people wanted more autonomy. They didn't want to just necessarily be kept alive on machines, for example. And so this idea that you could authorize withholding or withdrawing life-sustaining treatment became more of a battleground. And we've seen that shift so that now the ethics committee meetings we have in hospitals are actually more about withholding and withdrawing life-sustaining treatment against the patient wishes. It used to be that the patients were going in asking to have these things withdrawn. So that's a big, huge cultural shift, but it is not euthanasia. It is not physician-assisted suicide. It is a delicate situation, but we need to keep that in mind. So you have the right to deny unwanted medical treatment as the patient. But voluntarily stopping eating and drinking. I mean, nobody can force you to eat or drink, but this is, believe it or not, this is actually one of the tactics that's being put forward by the pro-death organizations. If you can't get your medical aid in dying, they just tell you, well, just quit eating and drinking and you'll die. So just keep that in mind. Palliative sedation. Again, we want to alleviate the suffering without alleviating those who suffer, right? Alleviate the suffering without alleviating those who suffer. Palliative sedation for somebody who is terminally ill and at the end of life and is in intractable pain is a viable pain management strategy. But what happens in the case of physician-assisted suicide or euthanasia, they will sedate you to the point where you can't be awake enough to eat or drink, and you dehydrate to death very, very quickly. And they'll say, wow, they didn't want anything to eat or drink. They could have, but they just chose not to. Well, it's because you kept them so drugged up that they couldn't. And this is one of the things, I get a lot of end of life calls in my office, as a matter of fact. And one of the things I hear the most often is that they morphined grandma to death. And they didn't morphine her with a lethal dose. What they did is they kept her so out of it that she didn't ask to eat or drink, and then dehydrated them to death. This is an issue. So again, a legitimate medical treatment is being somehow perverted to be used in a way to end life. And then the other thing we're seeing, refusals to provide care. Again, that is not the same as euthanasia. That is not the same as assisted suicide, but a lot of people get that blurred. Well, they're not going to treat my grandfather's, I mean, he's 92, he's got terminal cancer, and we want him a full code. We want to make sure that if his heart stops, he gets CPR. And the doctors are like, no, he's not a good patient for that. And then people will say, well, they killed my grandfather because they refused to do CPR. No, they didn't. But again, we want to be clear on our terms. So lots and lots of things are driving this train, if you will, toward physician-assisted suicide. I know Alex mentioned a few of them, but I'm going to touch on them again. The strain on public resources. Now, isn't Canada healthcare wonderful? Isn't the European healthcare wonderful? What happens when you provide quote unquote free care for everybody? It becomes very expensive, and the taxpayers then get to control what they want to pay for and they don't want to pay for. And this is one of the problems now we're seeing even with the Obamacare and the expansion of Medicaid, because when you have the government involved and the government is paying for things, then the government gets to control things. And that is one of the drivers we're seeing, because let's be honest, it's a whole lot cheaper to just have a patient be dead now than it is to continue treating them. So that is a definite driver of physician-assisted suicide. Whoops, sorry, going back. Whoop, wrong way. The cost of long-term care. Oh my gosh. My mom had a stroke earlier this year. She was in assisted living for a while. Can you say $6,000 a month? $6,000, and that was not even one of the more expensive ones, believe it or not. So that is a real problem, and it's something that I think that people who are on the other side of the physician-assisted movement need to address. Ed was right. We did address a lot of these drivers, and this is why Michigan's been protected for so long. But this is another area that either we get long-term care insurance or people are made more aware of it. But what happens is you find yourself in the situation where, okay, mom had a stroke and needs assisted living, and you are now saddled with this and you are unaware of it. It is not a discussion that's being had anywhere, and it needs to be had because it's a driver. Pressure from insurance companies. I know Alex mentioned some of this too, and we're seeing this really rearing its ugly head in some of the states that have legalized assisted suicide. And that is getting a letter from your insurance company saying, well, that experimental chemotherapy drug that might save your life, we can't pay for that, but we will pay for your assisted suicide medication. In the same letter. It's happening right now. Again, it's a whole lot cheaper for the insurance companies to just have you dead than it is to continue to pay for expensive medical care. Which brings me to my next point, is expensive medical care. As we've seen, again, whenever you get more involvement from more third parties and more private payers, and then we've got the public payers, and we've got Medicare, and we've got Medicaid, and now we've got Obamacare, and we've got all these other things, it ends up driving up the cost of medicine in a lot of ways. Not to mention, we've got a whole lot more laws in place, which is a good thing, but the cost of medical care in the United States is the highest. I think it's the highest in the world. And that's a problem, because people have to make a decision between, do I continue to pay for this, or do I choose assisted suicide? And as we've heard, lots and lots and lots of difficult circumstances are drivers to assisted suicide. Depression, loneliness, homelessness, disability, all of these things are part of what the physician-assisted suicide lobby is exploiting, as a matter of fact. And I'll talk about that in a little bit, but there are a lot of difficult circumstances out there. Obviously, society can't cure every ill. We can't. But the answer to societal problems is not to get rid of the person experiencing those societal problems, right? Again, we want to eliminate the suffering without eliminating those who suffer. So finding ways to deal with some of these difficult circumstances is going to be a challenge for those of us who want to resist the assisted suicide movement. And then, like we saw, or like we see all the time, you don't want to be a burden. You're going to be too expensive. You don't have anybody in your family to care for you. And so it's a subtle, or sometimes not so subtle, push to, the duty to die. So factors affecting physician-assisted suicide acceptance, because again, this is a cultural battle, a societal battle, and a medical battle, as well as a legal battle. But in the past 5 years, states allowing access to life-ending medication for the terminally ill have more than tripled, leading to the ad populum mentality. And if you take logic or Latin, Ad populum. We have all these storytelling. We have all this popularity. Well, they're doing it. This state did it. This state did it. This state did it. In fact, when I work on legislation, a lot of times the first question that is asked of me is, well, what other states have that law? What other states have that law? It's like, well, like you can't be original. But if other states are doing it, then you go, oh, well, if other states are doing it, it must be okay. And that's exactly what we're seeing. It's almost like the snowball effect. The other factors that are leading to an acceptance of physician-assisted suicide is church attendance is way down. One of the, I believe, and I looked this up, the number one religion in America. Ready? Who can name the number one religion in America? Falling away Catholics. Second closest is the nuns, N-O-N-E, none. They are no religious affiliation. We are at the highest level of no religious affiliation in our country's history right now. Well, get it right now. This hit this just this last year. 50% of Americans have no religious affiliation. Now, they may nominally consider themselves to be a quote unquote Christian, but they don't adhere to any religious denomination. They are not part of any church or synagogue or mosque. So that is definitely something to think about. And we are seeing much more radical individualism where we feel that we're in control. I don't mean to get religious here, but in a way, it's like there are those people that believe God's in control. And then there are those people that believe they're in control and that God is not. And we are seeing that in a whole lot of other areas in our society. And so I think that is also leading to this idea that I'm in control of my own death. Now, right now, we can't actually control when we die necessarily. Oh, yeah, but this is what they want. We can't control that we die. Let me rephrase that. Everybody's going to die. Nobody gets out of here alive. But this radical individualist idea is that I'm in control. I'm going to set the day and the time. And like Alex mentioned, they're even holding death parties. Death parties. Crazy. Less family, less community attachment. And we've seen this. Birth numbers have dropped in America. They are down at historic lows. We have fewer children. We have fewer families. And when I say community attachment, our families are spread out a whole lot more than they used to be. People are mobile. They move around. And I think we're seeing this double down with COVID and everybody started working remotely. You're detached from your coworkers. You're detached from people. And you can work in another state that you're not even affiliated with anybody there, right? So this idea that we have, less family and community attachment leads to what Alex was saying. It's not intractable pain that leads people to choose assisted suicide. It's more apt to be that sense of loneliness, detachment, burden, et cetera, et cetera. And these are all factors that are pushing that. And as Alex pointed out, the 4 W's, the people who are choosing assisted suicide, and we got the numbers from Oregon from last year, they are the white, worried, wealthy, and well. White, worried, wealthy, and well. White, worried, wealthy, and well-educated, actually, too. They are. Looking at the numbers, the percentage of Black individuals in Oregon who have chosen assisted suicide, 0.6%. 0.6%. The percentage of people who were well-educated, well over 50% of the people choosing assisted suicide have some sort of college degree. And looking at the areas from whence these people come in Oregon, they are the wealthy areas. So again, I don't know exactly why, but these are things that as we move forward in trying to stop physician-assisted suicide from taking a foothold in Michigan, we need to consider all of those demographics and craft our messaging accordingly. Oh, sorry. Am I stuck? There we go. So enter Compassion and Choices. Compassion and Choices is the leading physician-assisted suicide advocacy organization in the country. And I've got my notes here. Hold on a second. I wrote it on here. I didn't put it on my bullets. I apologize. Here we go. So Compassion and Choices was formerly called the Hemlock Society. Now you can all imagine why they changed their name. Hemlock Society didn't have a great ring. And they became End of Life Choices in 2015 or 2005. And eventually they became Compassion and Choices. But they originally began in like 1980. And they were located in Oregon, which is home to the first state to legalize assisted suicide. Interestingly enough, the very first bill ever introduced to legalize it was in Florida, and it never got passed there in 1967. But the goal of Compassion and Choices is to change the attitudes surrounding physician-assisted suicide, change the practices of the medical society, and to change the laws. So they have a three-pronged approach to how they're going about it. And they are active all over the United States, and they are working to expand in every state. They engage in all kinds of areas, and this is the interesting thing. Sorry. All right, there we go. They're clever. They're very crafty, because what I told you guys at the beginning was all those terminologies, right? All those different terminologies, and they kind of all blur together, and people don't really know, what does this mean? What does that mean? So Compassion and Choices actually engages in all kinds of parts of this whole process, including end-of-life planning. They do community outreach. They do legal advocacy. They do political advocacy, federal relations, access campaigns for hospitals to administer physician-assisted suicide. I'm going to pause there for a second. Access campaigns. They're literally working to try and infiltrate inside the hospitals and the medical associations and the medical communities, because how do we get medical aid in dying? We have to exploit the medical community. I mean, people can kill themselves. They've been doing that since the dawn of time. Suicide is suicide. But if you want medical help, you've got to convince the medical community somehow that this is a good thing. So, and of course, they have an army of volunteers. They are doing storytelling, misguided compassion. This is the way that they are changing the hearts and minds of the population. And how do you change a culture? How do you move from an acceptance of something to not accepting, or vice versa? And I want to use a really great example here. And this is something people in the room can remember. And I don't like to use this example, but it's fitting. How many remember 35 years ago being able to smoke everywhere? In the hospitals, in the airplanes, in your college classrooms, in the malls and restaurants, everywhere. And look at the cultural change that has taken place in the last 35 years on that area. It can happen, but it takes a big campaign. And that's exactly what these guys are working on. They are working to have that kind of cultural shift on physician-assisted suicide. And they have to go about it by convincing people, because how you move policy is you get people to demand that the policy needs to be moved. And that's what they're working on. So they need to change the culture. And of course, they're also involved in legal advocacy. Compassion and Choices, as Alex said, is suing. They've sued, over the years for lots of different things. They've been involved in fact, they were involved in the Glucksberg case and the Quill case, as a matter of fact. So, so we need to keep in mind that they're active, and they are organized, and they've been around for a long time, and they figured out what works and what doesn't work. They have long-term strategic goals, and they've laid them out. This is for everybody to go see it. You can go right on their website. I'm not telling anything that's not public. They have long-term goals to have and train 2,500 certified end-of-life care roadmap guides, similar to end-of-life care, but specific to physician-assisted suicide. But you see how they twist that? They're training guides who will go in and get embedded into the end-of-life care planning committees at hospitals and in doctors' offices, and they want to try and encourage this. And so that's one of their plans. They want to have 50% of all Americans living where medical aid in dying, or physician-assisted suicide, let's not give them their language, is authorized and accessible by 2028. That's 5 years from now. They hope that 50% of Americans will live in a state where physician-assisted suicide is legal and acceptable. And as Alex pointed out, by telemedicine. They may reach that goal because telemedicine is going to be available and they can ship the drugs anywhere. And that's going to be a problem. During the 2023 legislative session, 15 states introduced 25 different bills to authorize physician-assisted suicide, but thankfully none of them have passed. And I'm not exactly sure why, other than the fact that the stories from Europe and the stories from Canada are beginning to get out, and they're giving a little bit of pause. And so we need to keep the stories on the other side going. I know it sounds like a slippery slope, but we've got the data now. We've got the stories now. But these guys are slow and steady. They are taking an incremental approach to this, and they are they're working their way through. They're not daunted. But let me go. I want to talk a little bit about the medical community. One of the things that I worked on this year was to keep the position of the Michigan State Medical Society against physician-assisted suicide. I know that seems like a very nominal point, but again, these are these insidious little incremental changes. They try and go into these medical communities around the states, and they try and get them to just go from opposed to studied neutral. That's actually their terminology, studied neutral. Well, we're going to be neutral while we study this. Well, that's a step toward it. And with every state that comes to studied neutrality, they eventually go to acceptance. So one of the goals that Compassion and Choices is doing, and what they've done here in Michigan, we were able to stop it, fortunately, was to get the Michigan State Medical Society to go to neutral instead of opposed. Oh, there we go. Sorry. I'm way ahead of myself. The AMA, the American Medical Association, is currently also opposed to physician-assisted suicide or medical aid in dying. But again, there's this pressure. They have a federal lobby going on too. So there is pressure on healthcare providers to become providers of a physician-assisted suicide. And they blur the lines and the language. They're trying to get in medical school curriculums. They're trying to change patient expectations, which is really interesting. So from, like I said, 30 years ago, there was this shift in patients from the hospitals. They had to do everything. And patients were like kind of almost saying, please don't, please don't, please don't. 30 years later, we now have medical providers saying, I don't want to provide this treatment. I don't want to provide that treatment. It's time for you to be dead now. And we're seeing way more ethics committees on withholding and withdrawing life-sustaining treatment. So again, that shift in the medical providers toward an acceptance that it's just, you know what, you should just be gone now. You've lived a good life. You're suffering. You're a burden, all these kinds of things. And the sad part of it is many of them have come to believe that their role as a medical provider is to also then extend to ending life, I should say. And in fact, one of the things that has circulated around some of the medical institutions is death by donation. Death by donation. I think it's actually accepted in one of the European countries where you want to make meaning out of your life, right? You know you're going to die, but your kidneys are still good, or your heart is still good. So you go in and the doctor will literally remove your heart for donation and just leave you dead. It's coming soon if we don't stop it. So what's going on in Michigan? In the late 1990s, several bills to legalize physician-assisted suicide were introduced and called the Michigan Medical Self-Determination Act. Fortunately, we were able to stop them, thanks in a part to Dr. Jack, because he was so egregious that they were never able to move them. The most recent attempts, however, were to legalize physician-assisted suicide were in 2017. So that wasn't too long ago, only 6 years ago. And a previous attempt took place in 2016. Fortunately, in the last 6 years, we have not seen introduced bills. But again, we've continued to work in the space of the physician-ordered scope of treatment, expanding guardianships and those kinds of things, where we're trying to make sure that people have the care they need. The current Compassion and Choices efforts include talks with Michigan legislators. That's going on right now. They are here. They are talking to legislators. They're trying to convince the legislature to take another at bat at physician-assisted suicide. I don't know who they're talking to, but I know they're talking because I've had meetings with legislators and they've let me know that they are in favor of physician-assisted suicide, interestingly. Compassion and Choices is investing money in Michigan. They did a poll here just last month. And the way they word their polling, again, there's the way you word things, you can get the answers that you want. But they're claiming that upwards of 70% of Michiganders want assisted suicide. And they will use their quote unquote polls to continue to convince people, that whole ad populum thing, right? They are actively recruiting volunteers in the state of Michigan. You can go on their website. They're actively asking for people to start volunteering. And part of their volunteer efforts include talking to people about a physician-assisted suicide, talking to legislators, producing videos, these stories, the storytelling. So that's one of the things they're working on. They are terrified, as a matter of fact, of Canada. And they're terrified of how fast Canada is moving because they're right across the border. And they're almost like, guys, slow down a little bit. Everything that the other side is saying, you guys are making come true, and it's going to make it harder on us. So we need to highlight what's going on in Canada because the other side realizes that it's sort of the Jack Kevorkian scenario all over again, in that what's going on in Canada is going to thwart their efforts here. So it's our job to continue to highlight those kinds of things. And they're also terrified of the disability rights groups. As Alex mentioned, there was a lawsuit that was filed in California recently in April by the disability rights groups, because let's be honest, they're targeted. So what's going on in Michigan with the Michigan legislature? Currently, we have a 2-seat majority, Democratic majority in each chamber in the House and the Senate, and we have a trifecta, Democratic governor, attorney general, and Secretary of State. I mentioned that because having the Democratic trifecta is important with regard to getting legislation through. When you have one party rule, and if that one party agrees with you, it's a whole lot easier to get legislation put through. And part of the reason I think they're targeting Michigan now is because we have not had that scenario in 40 years. It's been a long, long, long time since they had that kind of thing. Now, the one thing I will mention is that this issue is not nearly as polarizing or partisan as abortion, in the sense that we have a lot of people on both sides of the aisle that we need to talk to, and this is not as partisan. So we will do that. Now, is Governor Whitmer going to sign a physician-assisted suicide law? I don't think so. I actually don't think she wants to, because she's got her sights on national. She wants to be somebody. She wants to be something. And this issue is not on anybody's platform. There are no national figures talking about physician-assisted suicide as a platform. Has anybody heard anybody? Not out there. So while Compassion and Choices may be wanting to make a play for legislation here in Michigan, I don't know that they're going to try, because I don't know that the governor wants to make this an issue. And I will point out that the Democratic majority in the House, they're going to possibly lose 2 members this November because they're in mayoral races, which will leave them at a split 50-50. They won't be able to move legislation. But again, that's assuming that this is partisan, which of course is what I think Compassion and Choices is assuming. And of course, they don't want to do anything too controversial because, believe it or not, 2024 is already on their minds. So while they may be setting the stage for later, I don't think we're going to see legislation this term. But will they try again with the ballot initiative? Michigan is one of 9 states that allows a citizens initiative initiated legislation and constitutional amendment. We're only a handful that allows citizens to do this sort of thing. So maybe they will. But as Ed pointed out, Proposal B failed miserably in 1998, 71 to 29. But he also pointed out it was not well organized, not well funded. But Compassion and Choices has an annual revenue of $23 million. Is that enough? Are there others out there? I've looked into who might be a willing funder of something like this, because ballot initiatives cost millions and millions and millions of dollars. So it's a possibility. It's something we need to keep our eyes open for. It won't be in 2024. It's a presidential year. It's expensive to run a campaign in a presidential year. It takes a little bit more to get going, but maybe they will try the legislative route first and then possibly a ballot initiative in 2026. These are speculations. I don't have anything hard and fast on that, but it's definitely something we need to think about. So we've got a lot to do to defend what we have in Michigan. And, but I think we've got some things on our side. So I'm going to open it up for questions. Thank you.
Yeah, we actually don't have a lot of time for questions, but we have time to talk at lunchtime. I'm going to I will make one little comment about Michigan, and that is whether they are able to win in next year or not is probably not a worry to them, because in every state they've done the same thing. They run a bill and they see all their legislators who are behind them, because they're building a campaign and they're not 100% sure the first time around what's going to happen. And so they're going to probably do it only, hoping they win, obviously, but they're probably going to think, well, even if we don't win, we're building our campaign, we're building our campaign team. We'll come, if we don't win this time, we'll get it next time, is how they're going to think. Or they might go to a plebiscite question once they've got their game rolling. So obviously speaking, the issue remains the same concern, because they are going to continue at us, and it's a prime thing. And as you know, Michigan's a prime state for them for several reasons, but it's a big state, but also because of how your elected representatives sit right now, how it looks. They wouldn't have had a chance 2 years ago or 3 years ago, whereas now they do. And that's, I'm sure, how they're thinking. They look at all the different states. They probably, anyway, I was talking to Peter Wolfgang and he can't join us. He has something else that just came. He was going to join us by remote. So we're going to call forward Meghan Schrader, and she's going to talk about her disability experience.
Hi, all. So I'm honored to present a disability rights perspective on assisted suicide. Before I begin, I want to make sure I provide a description for anyone who might be blind out there in our virtual or practical audience. So I am a white woman with freckles and red hair. I'm wearing a black and blue skirt with a blue scarf and blue pants. I'll do my best to make sure I provide simple explanations of the slides and also the images. But if you're disabled and I didn't provide an accommodation that you needed to access the presentation, please feel free to get in touch with Alex and get my contact information. And I will gladly do what I can to make the recording or the PowerPoint from the presentation accessible to you. So, okay. So since we're talking about assisted suicide that initially is limited to terminal illness, and we want to talk about empathy, I thought I'd go ahead and talk about my experience with terminal illness. I can't exactly know what the proponents have experienced because I am not them. But before I go on, I should say this is a picture on the slide of me, my biological mother, and my biological grandfather sitting in our room together hugging. So I can't know what the proponents have experienced, but in 2016, I suddenly lost my biological mother to cancer 2 years after I met her. We had become good friends. She got the diagnosis and she was gone in 2 months. Getting the news caused a psychotic break, and I had to say goodbye to her while I was in that state. That's the experience I'd use as a rubric for empathizing with the proponent's experience of a difficult death or a fear of a difficult death. So my experience with psychiatric disability, I want to talk about that because I know psychiatric euthanasia is a dark cloud on the horizon. I've had treatment-resistant depression from bipolar disorder and also some eating disorders since my mid-teens. So if you look at the slide, there's a slide from a cartoon called Hyperbole and a Half, where the author describes her symptoms of depression. She's lying on the couch with her arm down because she's so exhausted. So at times I have had red level symptoms. And there's a screenshot from the Red Wedding. If you've ever seen the Red Wedding scene from Game of Thrones, basically everyone is sitting there, things seem fine, and all of a sudden everybody gets horribly murdered. And I mean, it sounds funny, but I really have experienced sort of the psychiatric equivalent of that. And so I want to be talking a little bit about autonomy and mental illness. When you have symptoms of mental illness, autonomy becomes complicated. Being depressed is a little bit like being functionally drunk. There's scientific research behind that. A lot of us fit that rubric of Catherine Mentor, that young woman that went to the emergency room seeking help for her suicidal thoughts. We know we're sick. We're doing our best to seek treatment and make good decisions, but we kind of know our brains aren't really working the way they need to be. So you can still make some choices. I'm not saying we shouldn't make choices, but you're still sort of drunk, and the structure of care and support to make choices that are consistent with what the person would otherwise choose and that are consistent with real love for the person often don't really exist. So that makes the person both vulnerable, but also oppressed. I know we talk about a lot about vulnerability, but this is a psychiatric euthanasia and other forms of euthanasia of people with disabilities are oppression. And you don't have to be vulnerable to be oppressed. So offering assisted suicide to someone experiencing a mental illness is abusive, and it would exacerbate systemic abuse that people with mental illnesses and disabilities already experience. I wanted to talk about my experience with coercion. Now on the slide, there is a illustration from a 1920s eugenics pamphlet titled "Those Who Came After: A Word on Racial Responsibility," showing the yearly cost in pounds, shillings, and pence of educating a normal child compared to a deaf child, a mentally deficient and physically deficient child. This narrative is still very prevalent in our society. So I grew up in special education, and I observed a lot of people resenting special ed students for even existing. When I was in high school, the guidance and special education personnel aggressively tried to stop me from taking college preparatory classes and tests because I was in special ed. There were a lot of legal and structural factors in place that made resisting those efforts difficult and exhausting, and they still exist today. Around that same time, a bipartisan legislator, it was everybody's fault, lowered special education student achievement standards to save money. It was a lesson in what it's like to have your autonomy undermined by systemic prejudice. Special education also, I think this is illustrative, holds school personnel to a good faith standard of conduct towards students, just like PAS holds doctors to a good faith standard. That's a lousy standard for preventing oppression and abuse, and it's unjust for the proponents to create a system that allows people to be bullied into killing themselves. So I wanted to talk about my academic research. Disability is an essential component of the horror genre. I am not the only scholar to make this connection. I've got a picture of my book, or not my whole book, but the book that my essay appears in, Anxiety Muted, American Film Music in a Suburban Age. And then next to it, there's a picture of a book called Hideous Progeny, Disability, Eugenics, and Classic Horror Cinema. So revulsion toward disability and disabled people goes back to humankind's earliest history. Killing disabled people is an idea that echoes throughout history. I studied the use of film music to reinforce eugenic narratives about disability in horror film. The film music that I studied in the films I chose had a kind of love theme that communicated happiness and able-bodiedness. So when a person was happy with their family and they were, having these loving experience with their family, there would be this love theme using specific musical tropes. But at the films I studied, then the person would become a monster, which metaphorically would connote the onset of disability. And that would be the monster. There would be a monster theme communicating that person really wasn't a person anymore. And then the love theme would often return in scenes where the disabled monster was killed by a loved one. So this idea of killing disabled people as an act of love is deeply ingrained in our culture, You don't have to, again, it's not all the proponents' fault that they don't understand this. It's not their fault that they haven't been exposed to the concept of ableism or disability history or disability analysis, disability studies analysis. Okay, so most disability studies scholars that I know oppose physician-assisted suicide. So on the screen, there's a book called Disability Hate Crimes. Does anyone really hate disabled people? And the author of that book is a mentor of mine, Mark Shelley, and he congratulated me on my anti-assisted suicide advocacy many times. There's another screenshot called Recovering a Crispitology of Pain, Leaky Bodies, Connective Tissue, and Feeling Discourse. This is by a peer named Alison Patsavas, and she wrote a very beautiful essay about basically our culture sends the message that if you are in pain, you should die. And she tried to kind of reconceptualize that in terms of how do you accept that your disability causes pain, and how do you find a life of meaning when you're in pain. Then the last screenshot, or I have, no, we don't think our doctors are out to get us, responding to the straw man distortions of disability rights arguments against assisted suicide by Carol J. Gale, PhD. So when oh yeah, here it is. Okay, so disability studies literature contains a wealth of thoughtful academic arguments about why legalizing PAS undermines the human and civil rights of people with disabilities. So examples of scholars who have written about it or opposed it are Corbett O'Toole, Rosemary Garland Thompson, Bill Peace, Paul Longmore, Adrian Ash, Tobin Sievers, Mark Shelley, Ali Patsavas, Marcia Saxton, Andrew Dell'Antonio, Carol Galen, many more. In 2011, I was at a Society of Disability Studies annual meeting, and the keynote speaker said, I'm an agnostic, but if there's an afterlife, I can't imagine that Dr. Kevorkian or Osama bin Laden are enjoying it very much. And the entire room, which was full of like 300 disability studies scholars, cheered. So opposition to assisted suicide is deeply ingrained in disability justice studies and disability justice advocacy. All right, so I wanted to read this quote by Tobin Sievers. Okay, so surprisingly, quote, little thought and energy has been given to disrupting the belief. Well, before I go into that, I'm sorry, I forgot to describe the slide. So on the slide, there's a picture of the book that he wrote. So it's got like a man with a disability on it and two different ways of looking at the man. Okay, so he says that assisted suicide stems from a disqualification of disabled people as human. So he says, quote, surprisingly little thought and energy have been given to disrupting the belief that non-quality humans do exist. This belief is so robust that it supports the most serious and characteristic injustices of our day. Disqualification at this moment in time justifies discrimination, servitude, imprisonment, involuntary institutionalization, euthanasia, human and civil rights violations, military intervention, compulsory sterilization, police actions, assisted suicide, capital punishment, and murder. And this is a very well-known, very thoughtful, award-winning disability studies scholar. So I really wanted to go again into this kind of assisted suicide as a bastardization of autonomy. Autonomy, in my humble opinion, and most disability studies scholars, I would say, does not mean you can do whatever. And that's what the things on the screen is. So on the screen, there's a person driving a car, like behind the wheel of a kind of car. And it says autonomy doesn't mean to do whatever. And it's a good metaphor because you can't just drive wherever you feel like it. There are rules. And then there's another screenshot of something somebody tweeted out. And it says, you can't send your kid to school with chicken pox or go barefoot in a restaurant or take a dump on a public sidewalk. Your whole life, your whole life has been a trade-off between public health and individual freedom, whether you've noticed it or not. So the disability studies communities and the disabled justice community's conception of autonomy has a lot in common with the Latino culture. The disability justice movement emphasizes interdependence, autonomy with help, and autonomy that's experienced in relation to one's environment. And I apologize, I forgot to describe the slide. So on the top of the slide is a group of people. It's an ADAPT protest. It's a famous photograph from the American with Disabilities Act Capitol Crawl. It's got a American flag, but there's a picture of a person in a wheelchair on it. And then below that, there's a picture of people holding a flag together. The Latino and disabled communities' ideas about autonomy tend to emphasize making choices in consultations with one's community, family, or your chosen family. Now, not everyone has a family. Disabled people have experienced rejection from their families. LGBT persons have experienced rejection from their families. So there's a big tradition in marginalized communities of finding people to take on the role of family. And my family, I must say, through my struggles with severe mental illness, has treated me with deep tenderness. And I really think that the best way for us to fight assisted suicide is to be each other's family, really make those sacrifices for each other. The proponents' ideas about autonomy are sort of based on the experiences of primarily upper middle class, able-bodied white people. So people who don't really need very much help, people who don't really understand what it's like to have their autonomy constrained by systemic oppression, people who are just highly independent, and there is a big connection between Anglo-Saxon culture and that hyper-individualistic philosophy. That's why, but Latino culture and disability culture is an interdependent culture. So here's Paul Longmore's statement. Again, he's a famous disability studies scholar. His statement about disability justice and autonomy. And again, on the screen, there's a screenshot of his book, Why I Burned My Book, and other essays on disability. And he says, quote, "Some people with physical disabilities have been affirming the validity of values drawn from their own experience. These values are markedly different from and even opposed to non-disabled majority of values. They declare that they prize not self-sufficiency, but self-determination, not independence, but interdependence, not functional separateness, but personal connection, not physical autonomy, but human community. The affirmation of disabled values also leads to a broad-ranging critique of non-disabled values. The disability movement can offer a critique of the hyper-individualistic majority norms institutionalized in the medical model, which is like the way that medical professionals look at disability, and at the heart of the contemporary American crisis, which we are in. I mean, assisted suicide is one bad thing, but there are a lot of bad things, especially for people with disabilities. It's part of a network of very problematic situations. Okay, so assisted suicide very clearly violates the Americans with Disabilities Act. Now, the United Spinal Association's explanation of why PAS violates the ADA is the best explanation I have read. Suicide prevention is a public health service, and PAS undermines that service for persons with disabilities. Disabled or terminally ill people do have the right to waive their own rights, like people can waive their Miranda rights, but they do not have the right to waive them on behalf of disabled people as a group. They can't get rid of laws that guarantee Miranda rights for other people. PS laws take away suicide prevention from disabled people as a group, and PS laws exacerbate problems that disabled people already have accessing suicide prevention and accessing equality. So assisted suicide is generally functioning as an implement of systemic oppression. We can see that in Canada. So an issue here is systemic ableism. So this graphic that I'm about to describe is the best representation of systemic ableism that I have found. So if you, on the slide, there is a picture of a Venn diagram. And on the top, there's a circle that says not disabled enough. Then there at the bottom, there's a circle that says too disabled. And then there's a really small circle in the middle that says right amount of disabled. So if you're not disabled enough, you are thrown off of benefits. You die after being deemed fit to work. You're seen as a scrounger. There are no accessible, new suitable or accessible jobs. If you're the right amount of disabled, then you have inspiration porn. Now, inspiration porn was a term coined by disability rights advocate and public speaker Stella Young, who was also an opponent of assisted suicide. And inspiration porn basically means like the disabled person exists to inspire others. No, there's nothing wrong with inspiring others, but deciding that the person exists to serve you is not only wrong, but very subjugating. So at the bottom, if you're too disabled, there's no ventilator. If you catch COVID, there's social care cuts, independence thwarted, seen as burden, and at the very bottom, there's always assisted dying. So it's not possible to separate PAS from the matrix of oppression that disabled people experience. Disabled people are not the only group that experiences systemic violence. That's why intersectionality is valuable. My good friend, Anita Cameron, works on ADAPT's panel on intersectionality. People from other marginalized communities, such as people of color or LGBT people with disabilities, may face other specific challenges and experiences that need to be taken into account. But I must say, I don't believe that PAS would be tolerated for the able-bodied members of other disenfranchised groups. It wouldn't be acceptable to say, like, I want able-bodied LGBT people to just be able to off themselves because they can't stand living in a homophobic culture. So, you know, and of course, you know, legalizing assisted suicide will hurt disabled LGBT people because it will intersect with any kind of extra barriers. And of course, you know, disabled people of color and et cetera. So turning disabled people's suicides into a medical procedure, though, no matter what the disabled person's circumstances are, is a kind of fourth-class citizenship. I hate you so much that I don't even care if you kill yourself. In fact, let us help you. So disabled people are in a kind of abusive relationship with society. So this poll from 2023 says that a majority of disabled voters do not believe that politicians care about the disabled community. It's a little too small for me to read, but that's the basic gist. And I strongly agree with that perspective. In my experience, that's true. Both the political right and the political left embrace political narratives that reinforce ableist policies and attitudes. For example, people tolerating tweets from the Hastings Center telling disabled people to kill ourselves and give our organs away, as they did in January of 2023, is a consequence of the disabled community's invisibility. If disability were integrated into social justice discussions a little more, that just wouldn't be acceptable. And so we just can't trust society to police assisted suicide or anything else for abuse. So I wanted to go into assisted suicide as a kind of trauma for the disabled community. So on the screen right now are screenshots of tweets from disabled Canadians. So the first one is a person, like a cartoon representation of a person with a rainbow background. His name is Lee. And he said, Bill C7 is a nightmare. The devastating toll on the mental health of disabled Canadians cannot be understated. You are telling us that we are better off dead? So many disabled Canadians are taking that to heart and suffering more than ever. So Disability Filibuster, which was a group formed to try to oppose Bill C7, noted Liberal Party of Canada has two plans for tomorrow. Bill C7 to legalize euthanasia of disabled people who are not at the end of life will be voted on. They'll mark the 10th anniversary of Canada's ratification of the United Nations Convention on the Rights of People with Disabilities. And a woman, or I don't know, a person named Terry Bell Arts responded, here in the wild of civilized colonial Canada, we see an epic administering of salt in the wound, helping to set global precedent on the fatal mistreatment of people with disabilities. It's crushing. One of the lead organizers of the resistance to assisted suicide in Canada, Gabrielle Peters, tweeted, in the future, when an accounting is done, please don't forget to include the harmful impact of the mental and physical health of disabled people, even just in the discourse around Bill C7. I don't discuss this much, but as a sexual assault survivor, this experience has been very much like the worst of court and public discourse from decades past, minus having a lawyer to insulate some of it. We've been called lawyers, exaggerators, and accused of some hidden motives. Okay, so I do think that assisted suicide is a consequence of lack of K through 12 and post-secondary training in disability history. So that history is usually not covered. I must say the Black Stork, eugenics and the death of defective babies in American medicine and motion pictures since 1915 is the best source I know for tracing the connections between some of today's right to die rhetoric and the eugenics movement. The book recounts a similar divide between progressive and conservative clergy on assisted suicide. Now, not all of today's progressive clergy do support assisted suicide. Many oppose it, but very often it's more fashionable for the progressive clergy to say it's good and the conservative clergy to say that it is bad. Eugenicists presented their cause as being scientific, progressive, and humane. Opponents were depicted as religious and cruel. It shows a similar divide among political progressives about whether euthanasia is okay. So some progressives thought it was delightful and talked about it merrily over tea, and other people strongly opposed it. It shows a similar pattern of euthanasia proponents sort of loving and hating people with disabilities. So one of the main proponents said he was motivated by tender-hearted mercy, but then talked about how much it was how annoying it was to even observe a person with a disability anywhere near him. So those two conflicting ideas are still at work today. Okay, so lack of knowledge leads good people to do good things. Lack of knowledge leads good people to do bad things. A Connecticut legislator recently quoted Nietzsche's passage about doctors having a duty to kill people with disabilities without realizing that that's where the quote, "one should die proudly when it is no longer possible to live proudly" came from. Now, I read up on this legislator, and she struck me as a very nice person who even does things that I passionately support, like better services for special ed students or more housing for people with severe psychiatric disabilities. But leaders have a duty to be apprised of where they're taking their ideas from. But most people lack access to the information that would clue them in on how whatever political agenda they embrace might be harmful to people with disabilities. So it results in that kind of situation. So I wanted to cover the issue of euthanasia and the Nazis. I gotta say, you should avoid mentioning the Nazis at hearings on assisted suicide in the US. Unless you have a long, drawn out period of time to give a lecture on the history of euthanasia like I'm doing right now, don't bring it up because the comparison makes PAS opponents seem paranoid. Most people lack any historical context for the comparison. Hitler did not love any of the people that he killed, and the victims did not get to die on their own terms. People will cite something called Goodman's Law, which means anyone who brings up a Nazi, it's silly, and the argument is over. So it's best to focus on how PAS furthers existing structures of privilege and subjugation. And that would be true even if the Nazi program had never occurred. On the other hand, it is true that the Nazi T4 euthanasia program is frequently left out of mainstream discussions about the Holocaust. And again, that fits into that pattern of cultural invisibility of the disabled community. We learn about the Holocaust so that situation doesn't repeat itself. Are crimes against people with disabilities not worth preventing via historical knowledge? Do these crimes not matter and only the deaths of the able-bodied people were sad? I do think some knowledge of the eugenics movement and of disability history would make people less likely to tolerate some of the bioethics rhetoric, like Peter Singer comparing disabled people to chimpanzees. I think that this knowledge might make people a little more wary of euthanasia. You can join in efforts to add information about the T4 euthanasia program and other disability history events to discussions of world history, like by joining in legislative efforts to teach disability history in schools. But you can stick to more subtle discussions of eugenics. I think that is relevant and more understandable. So I wanted to read this passage from an essay by my colleague, Joe Stromando. So in eugenics, historical present day technology, Professor Joe Stromando notes, and before I go back, I have to describe the slide. So this is a picture of my friend Joe Stromando with his wife and their baby. He and his wife both have forms of dwarfism. And Joe has done a lot of study of eugenics. So when actions like these have become less common, while actions like these, such as forced sterilization, killing people, etc., the attitude that the existence of disabled people is a public burden and we ought to make efforts to remove them from public life remains exceedingly common. For example, while he was running for mayor of New York City, Andrew Yang suggested that unhoused disabled people be institutionalized so that they do not adversely impact tourism. Such comments must be understood in the historical context of the eugenics movement, which emphasized the ways in which the presence of certain undesirable people in the social milieu burdened or even directly harmed everyone else. This attitude toward disabled people can even motivate everyday people to have sympathy toward the most heinous acts. For example, in 2016, the mother and godmother of Alex Bordakis, an autistic boy, were released from prison after admitting they killed him. The judge showed leniency and sentenced them to only 3 years that they served during the trial because of the eugenic mindset that caring for Alex had supposedly been so burdensome that they had been driven to murder him. Such an outcome would be unthinkable if the murdered boy had not been disabled. Utilitarian treatises waxing rhapsodically about our right to die so that we can send the money spent on disabled people's needs to starving people in Africa as Peter Singer does in his effective altruism stuff is definitely eugenics. Okay, so this is going into the issue of eugenics and hate speech. I'll just kind of summarize because the writing on this particular graphic is small. But basically, there's a guy at the University of Texas at a conservative think tank there who strongly supports Canada's law. And he said that basically he'd want to kill himself if he were disabled and that he wouldn't want to accept his disability and that he wouldn't want to hang on and burden people. He didn't want to accept a defective version of himself. Law professor specializing in mental health care, Isabel Grant writes, "How is this not hate speech?" And law professor Trudeau Lemons writes, "His vile suggestions about who is better off dead would definitely be treated as hate speech if you change who he is talking about." Yet some of our colleagues endorse this crap with enthusiastic fervor. So legalizing assisted suicide enables hateful ideas. I am not saying that everyone who supports assisted suicide is a hater. I once had a pastor who supported it. But you normalize this rhetoric, it's hateful. Okay, so we have the wonderful connections between US and Canada. Thaddeus Mason Pope would like to turn the US into Canada, and he is a Hastings Center Fellow. Pope appeared on Dr. Phil with Compassion and Choices to promote conservative PAS laws. Stephanie Green, head of Canada's euthanasia program, has given presentations at Harvard Medical School and Stanford Medical School about how great her job killing disabled people is. Green hangs out with her US colleagues at Right to Die conferences in Oregon. I'm not going to read the whole tweet, but basically there's a picture of her tweet saying that she's hanging out with her US colleagues at a conference. Green's book is widely available in US bookstores and libraries. Twitter is a US company beholden to the Americans with Disabilities Act, but it lets Right to Die people send pro-suicide messages from Canada to people with disabilities. So really, Twitter is in violation of the ADA. Or it's called X now, but whatever. Okay, so connections between the US and Canada. Again, they're a picture of 2 tweets from Death with Dignity retweeting tweets from Canada and Canadian accounts. The Death with Dignity National Center is a member of the World Federation of Right to Die Societies, which supports expansive PAS, and the Death with Dignity National Center approvingly retweets tweets from Canadian accounts, including one from that maid house that helps impoverished disabled people die alone. So the Hastings Center tells disabled Twitter users that it's okay to kill ourselves. In January of 2023, the Hastings Center tweeted out an essay celebrating the fact that disabled Canadians were killing themselves and giving their organs to other people. So if you look it was on Twitter, there's a picture of some people doing surgery. It's a screenshot of a tweet, and it says, "Where does organ donation fit into medical aid in dying? Courtney Sass and Michael Schuyler, MD, fashioned an ethical answer based on Canada's practices." And then it has hashtag ethics, hashtag autonomy, hashtag decision-making, hashtag end of life, hashtag healthcare, hashtag organ donation, hashtag kidney disease, and hashtag med Twitter. So they clearly want lots of people to see this. I gotta say, the Hastings Center's choice to do that is violent and ugly. Disabled Twitter users did not collectively consent to be singled out for exclusion from Twitter's policy of users not being able to tell other users to kill themselves. And in my opinion, this is hate speech. Okay, so assisted suicide is systemic violence. There are many historical instances of violence against disabled people, and PAS falls into that pattern. In 2016, a Japanese man named Satoshi Yuta broke into a home for disabled people and murdered 19 residents. Now, nobody signed a consent form to be stabbed to death, as is done in euthanasia. But before he did it, he wrote a letter to Japan's government saying that disabled people were a burden on the state and, quote, "I want Japan to be a country where the disabled can be euthanized." He said that people with disabilities were a burden and that they needed to die for the good of Japan. The broader right to die movement, the people in, I do know some people who supported for terminal illness who would not go in this direction. I get that. But the broader right to die movement employs the same rhetoric. The broader right to die movement's proposals about disabled people fit into a pattern of systemic violence against disabled people. It's just a kinder, nicer, gentler way. Instead of stabbing them, you overdose them. Okay, so the United Nations identifies euthanasia as undermining the human rights of people with disabilities. And this is a picture of the headline of their statement. It says, "Disability is not a reason to sanction medically assisted dying." UN experts. UN said Canada's MAID law violated the UN's Convention on the Rights of People with Disabilities. Quote, "The experts said that even when access to medical assistance in dying is restricted to those at the end of life or with a terminal illness, people with disabilities, older persons, and especially older persons with disabilities may feel subtly pressures to end their lives prematurely due to attitudinal barriers, as well as the lack of appropriate services and support." So this is a quote from my friend Harold Braswell. On the slide, there's a picture of Harold, and then and then below it, there's a picture of an article he wrote called "Silence is Not an Option." Bioethicist and disability studies scholar Harold Braswell wrote in the Washington Post article, "Canada is plunging toward a human rights disaster for disabled people." In an interview on his article, he notes, quote, "Imagine if we stopped trying to prevent suicide among African Americans, women, or LGBT individuals. It would be viewed as an almost unimaginable form of bigotry. But this otherwise obvious bigotry goes unnoticed when leveled at disabled people. This is because while those other categories are largely viewed as social, hence subject to discrimination, disability is considered primarily medical. When disabled people suffer, as they, like all people do, this suffering is presumed to be inherent to their disability, part of its biology. When this disability can't be cured, killing the disabled person seems like the only way to end their suffering." In that same interview, Braswell notes, quote, "From the US, what's happening is at a minimum a cautionary tale. Less than 5 years ago, Canada legalized PAS for terminally ill people, as we are increasingly doing now. Now, in the midst of a pandemic, they are revving it up for the same people that they left to wither in nursing homes. Conservative PAS has undoubtedly primed the pump for its less careful counterpart." Okay, so it's understandable that some people, I got to do, okay, so first, do no harm. The proposed definition of terminal anorexia is fraught with danger for vulnerable individuals. And then psychiatric euthanasia, suicide, and the role of gender. Those are the two pictures on the screen. So it's understandable that some people would draw a distinction between PAS for the imminently dying and the suicide of a distraught teenager, but suicidal ideation is more subtle and complicated than that. In the Netherlands, recipients of psychiatric euthanasia mirror the same gender-specific suicide patterns. Women are twice as likely to die by psychiatric euthanasia as men. Canada is set to legalize PAS for mental illness in 2024. Okay. One important development is the retraction of the American Association of Suicidology's "Made is Not Suicide" statement. So in 2017, the AAS made a statement that aid in dying was not suicide, but tragically, this statement was used in the 2019 Canadian Trichan decision that extended MAID to disabled Canadians. This change was opposed by the Canadian Association for Suicide Prevention. So the AAS retracted its statement about MAID not being suicide in 2023. So that's important. According to research, according to research, a 2020 study by Lund et al. Found that people were more likely to see suicide as acceptable if the person had disabilities. Okay, so as we know, euthanasia undermines assisted suicide in Canada. We already know that. I just want to do a brief public service announcement. Just because we should give suicide prevention does sometimes morph into behavior that is paternalistic and abusive. So make sure you're not supporting policies like forcible long-term involuntary hospitalization. Make sure that you're listening to the concerns of disability rights advocates concerning things like outpatient commitment. But obviously, compassionate suicide prevention based on love and respect saves lives. Okay, so one example of a good project that sadly isn't around anymore is the Live On project, and it was a really great project designed for disabled people. It was a suicide prevention resource targeted at disabled people. It integrated a lot of concepts about disability justice, but unfortunately it was defunded shortly after it was started. There is a lack of suicide prevention resources targeted to people with disabilities. It's definitely an underserved population. All right, so I'm going to end by talking about my Canadian friend, Amy. Amy was a Canadian woman who I sent a couple of supportive tweets to and a private message to her and one other woman who were struggling. And she was moved by the supportive messages. So she reached out to us after she was offered, after a suicide prevention hotline operator told her that perhaps she should consider ending her life with MAID. Now, Amy was in very, very severe pain. I don't have time to read every tweet of Amy's that's depicted on the screen. There's a, on the screen, there are pictures of our conversations with Amy with, of course, her identifying information blacked out. So she had suffered from PTSD from child abuse, and this caused her to relive the child abuse and made euthanasia seem attractive. Amy said that her the country's euthanasia program was a monkey on her back, urging her to die. So Amy did not want to hear your body, your choice. She said she needed someone to tell her unequivocally not to kill herself. She needed the message that euthanasia was bad. So that's what we did. We told her euthanasia was a bad option and she should not do it, just like prevention hotlines are supposed to do. So I do want to quote this quote from her. MAID has made everything so difficult, hasn't it? It's kind of rhetorical. Some things like life is always worth fighting for should be a black and white subject. But when someone now has the legal right to assisted suicide, there's so much bloody gray. So for months, we talked to Amy pretty much every day. And whenever she thought about dying by euthanasia or some other way, we helped talk her down. We essentially took the place of the suicide hotline that told her to kill herself. We became good friends, the three of us, like a sisterhood. We talked about our childhoods, our religious beliefs, our similar experiences with the unremitting health problems, the ableism we had experienced, and our hopes for the future. There was this one really tragic night where I really felt afraid that she was going to apply for euthanasia, or maybe she was seriously thinking of killing herself some other way that night. I'll just do a small quote. She said, "I refuse to hope anymore. It hurts too much. I'm not saying I'm giving up tonight, but I'm saying I might. I'm sorry." So we managed to help her regain the will to live. I called my therapist for advice at 1 a.m, and talking about great leaders who had also experienced suicidal ideation really helped Amy out. So by working with other disability rights activists and a euthanasia prevention organization, this very one, the EPC, we were able to get Amy some assisted devices to make living with her physical disabilities more manageable. Amy finally mustered the courage and financial support to take a train 4 hours away from her house and show up at the emergency room of a hospital that specialized in treating chronic pain and mental health. This was after months and months of getting no relief from doctors, going from doctor to doctor. She finally received excellent care. She says that she still experiences chronic pain and PTSD, but that the pain is manageable. She is not planning to die by euthanasia, but the Canadian system would have killed Amy before giving her the treatment that she needed. So peer support was critical for Amy. Again, I'll try to summarize this because I know I got to get going. Without the mutual experience of disability, it probably would have been harder for us to help Amy. And so peer support, where we had all been through these terrible experiences with our own health and the medical system, it was critical to giving her hope. So I think, again, I'll just summarize here. I have a picture of myself and my cousin, my brother, his wife, and also me, Anita Cameron, and another a legislator, Tom Harkin. We basically have to be each other's family. We have to take the place of family that isn't there for the individual to fight a culture that doesn't really care very much about people. Also, everybody needs to put disabled people first. People in all sides of the political spectrum have really failed people with disabilities. So you got to fight for disability rights with no other personal or political agenda. Disabled people deal with very severe oppression that would exist even if there were no PAS. So call attention to that oppression and try to fix it. Examine your political narratives for ableism. Fight for things like good educational opportunities and fight against institutionalization and subminimum wages. And this is, oh good, this is the last slide. Okay, so I wanna make sure I describe this picture. On the top, there are 3 Black women. One is using a wheelchair. Another one is, there are 3 women, like they're looking at something together and smiling. And there's a woman with like pink hair and then 2 other women with natural hair. And then again at the bottom, there's a picture of the Disability Rights Capitol Crawl with an ADAPT American flag with a picture of a person in a wheelchair on it. So that's my recommendations. Thank you so much.
So the group here in-house, we're going to go to have our lunch. We're going to return at 12:30 sharp. So please look at your watches. We have Wesley Smith starting at 12:30 sharp. If you're in California, that means we're starting at 9:30 sharp. So have your breakfast. Anyway, and I do have a few questions here, but the people in the room will now go to lunch, and we're going to stop the recording and restart it again at 12:30. Thank you very much. Now, someone earlier asked me, who is Wesley Smith? And I know Colleen's supposed to be doing introductions, but because I'm standing here, I'm just going to steal it from her. Wesley Smith just happens to be one of the people who've been involved in this issue, not the longest, but pretty close to among the longest. And I know I'm in Michigan, so that's hard to say because Michigan had the battles in the early 90s with Kevorkian. Nonetheless, he's a bioethicist who's written extensively on this. And my comment to the person who asked me just a few minutes ago, who is Wesley Smith? I said, Google him, because obviously it comes up pretty quick who he is and what he's about. So for many of us, this is one of our great thinkers on the issue for many years. So thank you, Wesley. And you can get started, and I'll make sure the volume's good for you.
Thanks. I ask that question all the time. Who is Wesley Smith? I've actually been doing this since 1993. I wrote my first anti-euthanasia piece in Newsweek magazine. I was not involved in that issue at that time. I was writing books with Ralph Nader. And a friend of mine killed herself under the influence of the Hemlock Society. And I was so upset about it. I wrote a piece that I considered to be a one-off called The Whispers of Strangers. And if anybody's interested in reading it, it's available online. Just put in Wesley J. Smith, Whispers of Strangers. It'll come up. Came out in June of '93. And in that piece, I described my friend Frances and her suicide. And then I worried about the future of the society if this euthanasia attitude continued. And one of the things I warned about at that time in '93 was that if people accepted killing as an answer to suffering, we would end up conjoining organ harvesting with euthanasia I said, as a plum to society was the term I used. And I thought my piece was completely uncontroversial, to be honest with you. I thought these euthanasia, hemlock society types were really fringe, that people would never get on that bandwagon. And I was doing a one-off kind of warning because I had the ability to get into which was then a very notable publication called Newsweek. And the reaction to the piece stunned me. I received about 150 pieces of mail. Now realize that in those days, if somebody wanted to tell you to get cancer, they had to take something called paper. Here's some paper here. And they had to write on it or type on it. And then they put it in something called an envelope. And then they had to pay to actually tell you to get cancer and die suffering by buying something called a stamp. There was no email. There was no sudden link. And about 125 people felt so strongly out of the 150 about my piece, were so negative towards it, that they took pen to paper or typewriter to paper and just sent me really vicious hate mail. And I was really taken aback, as I didn't expect it. And I thought to myself, when did my culture change and where was I when that happened? And as it happened, many of your attendees will know who Rita Marker is. And Rita reached out to me. I didn't know Rita at the time. And at that time, her organization was called the International Anti-Euthanasia Task Force. And she asked if she could reprint the piece in the newsletter of the International Anti-Euthanasia Task Force. And I said, of course you can. And then I remember saying, Rita, are you aware that these people think? And she said, yes, Wesley, I know. I said, do you know what they want to do? And she said, yes, Wesley, I know. And I was so concerned about this that I said I would like to give her 10% of my time. And she started to send me these packages. And this is, again, before you could send links on email and so forth. Every 2 or 3 days, I'd get this big manila envelope filled with clippings about the Hemlock Society, about Jack Kevorkian and so forth. And you can see what happened to the color of my hair as I read all of that. And I decided to devote more time to it. So then it was 20%, then it was 30%. I had some talents she could use. I kind of became the primary spokesperson on radio and television. I debated Jeffrey Feiger, who is Jack Kevorkian's lawyer, on ABC Good Morning America, on the Charles Grodin Show, and other places. I started to appear on national radio and television interview programs on this issue, back when the media actually gave people who oppose assisted suicide a voice. Of course, that's been gone since about, I'd say, the year 2000. They no longer care what we think. It's only one way, and that's the pro-death way. So I've been doing this for more than 30 years. And eventually I left working with Ralph with his blessing, and started to do this full time. And then my other work, the euthanasia, took me to the bioethics issue and took me to a lot of other issues. So I'm now involved in what I call human exceptionalism, which is protecting human dignity, intrinsic dignity, moral worth, and also the obligations we have as human beings, which is human exceptionalism has two sides to the coin, our value and our moral duties. And of course, one is to take care of people and help people who are going through darkness and despair, who are suicidal for whatever reason, but including based on illness or disability. And sometimes people say, why do you think this is so important? And there's a story that just broke that I think illustrates it. And I've just written about it. And it's about a 16-year-old girl with a brain tumor from Belgium who asked to be euthanized and have her organs harvested, like I predicted. She was 16. Doctors agreed. She was sedated and intubated in the ICU for 36 hours while they examined her organs. And I'm assuming the examination, since it was not in the surgical suite, but the ICU, was things like imaging and blood tests and that kind of thing. And then she was killed and her body stripped of her organs. And I had three thoughts about this. First, this is a minor. This is a child. She couldn't consent to a tattoo. And yet she was clearly terrified of going into decline, but also stated that by donating her organs, she could do some good for the world. And so it seems to me that the organ harvesting option could have been the tipping point that induced her to actually make the decision to be killed. Because people, when they're in extremis, when they're scared of dying, when they've got serious disabilities or perhaps mental illnesses, sometimes think, well, my death could be of greater value than my life, and it gives them a purpose. And so it seems to me, we don't know, but that in this case, one of the reasons she may have decided to be killed was this organ option. Second, as far as we know, she wasn't provided suicide prevention. It should be that anyone who's suicidal, and if you're going to ask for a lethal jab or if you're going to ask for a lethal prescription, you're suicidal, that the very first reaction in any case, every case, should be suicide prevention and focused support to help them overcome the fears that are driving them to such a decision. And of course, she probably did not receive that because in Belgium, euthanasia is not only legal, it's very well accepted. Third, the lengthy sedation and intubation to which she was subjected wasn't about helping her. That was done solely for the purpose of examining her organs and finding compatible recipients of those organs. And so that illustrates what happens. Once somebody is deemed killable, they become objectified. And her organs were deemed more important than her life, with the great excuse of, well, this is choice. Well, this is abandonment is what this is. And so you can see, and you're seeing that also in Canada, which I'm sure you may have already heard about or will hear about later. Canada's going even further than Belgium and the Netherlands in supporting euthanasia, which is really a terrible concern to Americans because Canada's our closest cultural cousins. In fact, many people in the United States think of Canada as our more enlightened, relatives. And it used to be that when I would point out things that are awful stories out of the Netherlands or Belgium, the other side, assuming we could be in a debate, which is very rare these days because our side isn't taken into account by the media, and usually the other side will refuse debates. At least they do with me. They'll say, well, the United States isn't the Netherlands. Well, United States is pretty close to Canada. So that no longer works. And this issue of organ harvesting as a plum to society, despite my being called an hysteric and alarmist and so forth, has come to pass. Because once a group of people or a category of people is considered having a life not worthy of life, well, then there's not really much we can't do to them or benefit from them. So this is a very real concern. And some of the very people who said I was an alarmist now say, well, of course we should take their organs because we might as well get some good out of their deaths. Well, that's the utilitarian mindset. And that's what gives society a stake in euthanasia. Society has a stake in euthanasia based on the organs, based on the money that can be saved. We've seen a lot of reports out of Canada about how this is saving millions of dollars for the Canadian Health Service, which apparently is in some extremis and difficulty right now. We've seen that when I used to make that argument about HMOs, health maintenance organizations, the very people who hated HMOs would say, well, there's no evidence that HMOs would cut costs by causing death. Oh, please. So this is I think the money issue is also a very strong inducement. But so what's really going on, though, is ideology, and it's a change in our perspective as cultures as to what's the most important purpose of organized society. And I'd like to share with you what I think has happened in that regard. There was a book written several years ago. It was about the stem cell issue, which we're not going to get into, by a moral philosopher named Yuval Levin. Yuval Levin was a staff member on the President's Council on Bioethics during the George W. Bush presidency under Leon Kass, the great bioethicist, who now, by the way, lives in Jerusalem. So say a prayer for he and his family. I have heard from him. He is safe, but his granddaughter is being called up, and it's a very difficult circumstance over there right now. But in any event, Yuval wrote a book called Imagining the Future, in which he tried to explain to conservatives why the left might support embryonic stem cell research, and to the left why conservatives or the right might oppose it. And again, we won't get into that. But he did have something that he wrote about early in the book that was really revelatory to me. I'd always asked the why now question to myself. Why now when 150 years ago, if you got bone cancer, you probably did die in agony. If you got had a burst appendix, you probably did die in agony. And yet 150 years ago, 100 years ago, there wasn't much, if any, real push for euthanasia. Maybe a little bit of trickle here and there in the late 19th century, but not much at all. And yet today, when we actually can substantially alleviate pain and suffering, when we can have interventions that bring about a tremendous improvement in people's lives, whether they're dying or whether they have serious pain issues or disabilities, suddenly we're talking about, quote, death with dignity, as if dying naturally isn't dignified, or the euphemism aid in dying, which of course isn't real because it's a euphemism. Assisted suicide or euthanasia are the proper terms because they're both descriptive and accurate. Suicide isn't why something is done, it's what is done. Kill oneself. And when a person receives a lethal prescription and swallows it and dies, that's what they've done. So we cannot allow the media, which just immediately glommed onto the pro-euthanasia side's lexicon, we cannot fall into that trap. I never use MAID, medical assistance in death or in dying, or aid in dying, or death with dignity, except if I'm having to quote somebody who's pro that, or when I try to describe MAID as a gooey euphemism to try to deflect from what is actually being done, because we're talking about killing here. And so I use accurate and descriptive terms, but I don't use tactful terms. And I think that's important because we can't yield to the other side's terminology, because as several people have noted throughout history, he or she who defines the terms wins the debate. In any event, in Imagining the Future, Yuval Levin wrote about Descartes. And here's what he wrote. Determined as we have seen that his new science should be directed to the advancement of health, and the notoriously doubtful Descartes was awfully bold in describing health as without doubt the primary good and the foundation of all other goods of this life. Surely the claim that health is the primary good has consequences well beyond the agenda of the scientist. Any society's understanding of the foundational good necessarily shape its politics, its social institutions, and its sense of moral purpose and direction. How you live has a lot to do with what you strive for. And health is an unusual candidate for the primary good. It is surely an essential good. Without health, not much else can be enjoyed. But Descartes' formulation in the worldview of modern science sees health not only as a foundation, but as a principal goal. Not only as a beginning, but also an end. Relief and preservation from disease and pain, from misery and necessity, become the defining ends of human action and therefore of human societies. So what he is saying there is that the purpose or the prime directive of society has shifted from protecting innocent human life or promoting righteousness to preventing and eliminating suffering. And if the primary purpose of society is to eliminate suffering, that very quickly morphs into eliminating the sufferer. And also the very concept of suffering itself becomes highly malleable. So suffering can be that of the patient, but it can also be that of the family. And we've seen many times where advocates for euthanasia and assisted suicide and doctors say, well, you know, the family's suffering so much, so this is best for everyone. or it can become the suffering of the medical team and it's very difficult to help people with serious conditions. And I've seen advocacy, well, the medical team shouldn't have to experience the emotional turmoil of dealing with patients who are dying or patients for whom there's probably no improvement going to be provided. It can also become the suffering of society, for example, the cost of care, or people saying, well, I don't want to see those kinds of people. And you see that people with disabilities suffering that kind of discrimination quite a bit, where people wish to turn away or wish they would just stay in the homes and so forth. One of the things I like about disability rights activists is their edginess. And the first time I was dealing with some disability rights activists, they said, well, you're a tab. And I said, what's a tab? And they said, temporarily able-bodied. And I thought that was good because it's true. All of us have the potential to become disabled, become serious. All of us at some point, if we're not hit by a truck, probably will become seriously ill because mortality is part of human existence. And so it's really important that we have solidarity with each other. Whatever we might believe on politics or other issues, when it comes to assisted suicide and euthanasia, it seems to me that the opponents have both the liberal side, that is protecting the vulnerable, and the conservative side, which is establishing and protecting very important institutions like the ethics of medicine. And so I'm always noticing and very pleased when euthanasia and assisted suicide proposals and legislation get turned back. And when they get turned back, it's because of a very dynamic and healthy coalition that forms among and between strange political bedfellows, because we agree completely that this assisted suicide agenda cannot continue forward, or you end up with like what we saw at the beginning of my talk, that poor 16-year-old girl being treated as so much of an organ farm more than a patient. Now, the bioethics movement is part of causing this attitude and doing away with the concept of the intrinsic dignity of human life. And I want to share with you a danger, because it leads to this idea of, among many other evils, that euthanasia is appropriate and ethical. And this is an article that was written some years ago, in fact, in 2009, by a bioethicist named Alistair Cochrane, Cochrane, in the professional journal Bioethics. And he was pushing for what he called an undignified bioethics, by which he means human beings do not have intrinsic dignity, do not have intrinsic moral worth, do not have something that is important of value simply and merely because we're human. In other words, anti-human exceptionalism. And he wrote it so brilliantly and cogently that I quote from it a lot, because he says better than I have why intrinsic dignity is important, and illustrates the consequences of rejecting it. And here's what he writes. Well, first he talks about human dignity as, how we behave. So, we all have acted undignified in our lives. My wife says that whenever I dance with her, she has that sense that I'm not very dignified, or the Three Stooges, right? But that's not what he's talking about. What he's talking about is dignity as a form of being. Quote, the second important conception of dignity that we need to consider does not see dignity as a form of behavior, but as a property. Under this conception, the possession of dignity by humans signifies that they have an inherent moral worth. And it's very important. In other words, because human beings possess dignity, we cannot do what we like to them, but instead have direct moral obligations toward them. That's human exceptionalism. Indeed, this understanding of dignity is also considered to serve as the grounding for human rights, which it is. As Article 1 of the Universal Declaration of Human Rights states, all human beings are born free and equal in dignity and rights. Very well stated. And that these are the stakes that are at risk here when we start to euthanize, the human exceptionalism, when we start to allow people to be killed based on fear of suffering or a loss of dignity fears, or pain that isn't being properly ameliorated and so forth. We objectify those that are going to be killed. He goes on, the conception of dignity as inherent moral worth certainly seems coherent enough as an idea. Indeed, we can also see why this conception of dignity is employed in certain debates around bioethics. For if all individual human beings possess dignity, then they should not be viewed simply as resources that we can treat however we please. And I submit to you that that 16-year-old Belgian girl was treated as a natural resource, as a corn crop ripe for the harvest. He goes on, to take an example then, it may be that we could achieve rapid and significant progress in medical science if we were to conduct wide-ranging medical experiments on groups of human beings. However, because human beings have dignity, so it is argued, this means that they possess a particular quality that grounds certain moral obligations and rights. And of course, he's right. And I would point out that Jack Kevorkian, back in the 90s, when he was doing his assisted suicide campaign, and he was the first person that that campaign was the first major thrust of euthanasia with which I engaged. His real goal was not to alleviate suffering. He wrote a book called Prescription Medicide. And in Prescription Medicide, he said that alleviating suffering was not his purpose, that was a unfortunate professional obligation, as he put it, but his real purpose was to conduct medical experiments on people he was euthanizing. He was very specific, very clear, and without apology. He called it obitiatry. Kevorkian used to like to make up words. And obitiatry was medical experimentation on people being euthanized. And what Kevorkian was obsessed about was to figure out what death is. And he wanted to do euthanasia and medical experimentation, watching people die through conducting experiments on their brains as they were dying and conducting experiments on their nervous system. He never got that opportunity, but his whole goal in his assisted suicide campaign was to make it so that he could do that. And he almost did it because the society had become so morally weak that it would not convict Kevorkian of clear violation of the assisted suicide law. And then eventually a DA was elected on the plank of not in what's the name of the county ever in I forgot the name of the county in Michigan where Kevorkian lived, but the DA ran on the plank of not prosecuting Kevorkian so long as he didn't embarrass the DA, kept it assisted suicide. Well, what did Kevorkian do immediately thereafter? He lethally injected Thomas Yoke, who was dying of Lou Gehrig's disease, ALS. And then he brought the video to 60 Minutes, which was shown on the air. And I remember Mike Wallace saying, is he dead yet? Is he dead yet? And Mike Wallace of 60 Minutes was a huge euthanasia booster. And Kevorkian was saying, no, he's not dead yet. He's just sedated and so forth. And that was actually the final bridge too far for the Oakland prosecutor because Kevorkian had embarrassed him. And he'd also exposed that it wasn't about alleviating suffering. It was about pursuing Kevorkian's agendas with human experimentation. And I thought about this 16-year-old girl. What if she had said, instead of, I want to be an organ donor, she had said, why don't you, when you're euthanizing me, experiment on me? What's the difference between those two scenarios? I don't see it. And while I don't know of any cases where that has happened yet, I don't see why it wouldn't. If we're going to kill people, why not get as much benefit from them as we can, whether it's experimentation, whether it's medical experiments to test new drugs or whatever it might be, in addition to taking their organs. So this whole idea of objectification is very important. I won't go into too much about why Cochrane says that we should not have intrinsic human dignity. He says what we should do instead is determine what creates value and then moral value traits, capacities. So, for example, if we decide that having the ability to make moral decisions is a trait that's of importance morally, then those human beings that have that trait might be protected, but those human beings that cannot express that trait, such as people like Terry Schiavo after she was suffered her brain damage, or newborn infants and so forth, they do not qualify for full moral status. And he ends up he finishes this way. Obviously, given controversies over abortion, stem cell research, genetic interventions, animal experimentation, euthanasia, and so on, bioethics does need to engage in debates over which entities possess moral worth and why. But these are best conducted by using the notion of moral status and arguing over the characteristics that warrant possession of it. Simply stipulating that all and only human beings possess this inherent moral worth because they have dignity is arbitrary and unhelpful. Yeah, it's arbitrary and unhelpful if you don't want to strip mine people for their organs. If you want to strip mine people for their organs, it's unhelpful if you want to be able to kill the sick so that they don't cause suffering, whether it's financial to families or experience it themselves. It's unhelpful if you want to dehydrate people with cognitive disabilities to death and so forth. And we're going to get to that a little bit toward the end of this presentation. But I think what Cochrane has done in his piece is illustrated the importance of universal human equal dignity. We're talking about human equality. This is not religion. This is human rights, universal human rights. If every human being is not inherently equal, objectively, simply because they're human, human rights can never be universal, because you're going to have people with the power deciding what matters, and those people who possess these attributes will be protected, and people that are deemed as not having it will not be protected, will be objectified and exploited. That's the history of the human race, which is why equal intrinsic dignity of all human beings is the bottom line. We can never yield on that, because once you've yielded on that, the whole ground falls, and you have a inability to protect against killing and objectification and exploitation and so forth. Some of the primary purposes of bioethics in terms of deciding which human being is killable and which is not is based on what they call personhood, or whether one is a person. In mainstream bioethics, utilitarian bioethics, every human being is not a person. And I'm going to read just a couple of quotes. These have been around a while too, but this is very mainstream thinking in bioethics, including now today in 2023. This is an article called "The Concept of the Person and the Value of Life" by John Harris. John Harris is a major bioethicist in the UK, and I'm not sure if he's still active, but he was very influential in the National Institute of Health and Care Excellence, NICE, in the UK. And he wrote this in the Kennedy Institute of Ethics Journal, which is one of the most prominent bioethics journals in the world. Many, if not most, of the problems of healthcare ethics presuppose that we have a view about what sorts of beings have something that we might think of as ultimate moral value. Or if this sounds too apocalyptic, then we certainly need to identify those sorts of individuals who have the highest moral value or importance. Think about the invidious nature of that statement. If he had said we have to decide on the race that has the highest moral value or importance, we would properly say, you, sir, are a bigot, because we do not divide people by greater value and lesser value. But what he's talking about are people who have severe or significant cognitive disabilities. And I submit that's the same invidious discrimination and bigoted thinking as racism, just different victims, and victims that are less able to protect themselves. He goes on to say, personhood provides a species neutral way of grouping creatures that have lives that would be wrong to end by killing or by letting die. Species neutral meaning bioethics generally accepts the concept of speciesism, that if you treat a human being as having greater value than an animal, it's akin to racism, and it's a wrong called speciesism. I have a whole speech on that question, which we won't get into today, but that's what he's talking about there. These may include animals, machines as transhumanism, the idea that if a machine is ever conscious, machines should have rights. And you see a lot of argumentation in favor of AI rights in transhumanism and in futuristic advocacy. And again, I could speak on that for an hour and I won't, but that's what that's about. Extraterrestrials, gods, angels, and devils. He's being sarcastic there. He says, persons who want to live are wronged by being killed because they are thereby deprived of something they value. So killing ceases to be wrong and becomes totally relative. If you value your life, you shouldn't be killed. If you don't value your life, you can be killed, and there's nothing ethical or unethical or immoral about it. He writes, persons who do not want to live are not on this account harmed by having their wish to die granted through voluntary euthanasia, for example. Then he goes on, non-persons or potential persons cannot be wronged in this way because death does not deprive them of something they can value. Non-persons are people diagnosed with unconsciousness, or they are newborn babies, because those are potential persons because the babies have not yet, because of maturity, developed those capacities. And so this whole view opens the door to infanticide. And we all know Peter Singer is the most famous advocate for allowing infanticide. And by the way, infanticide does happen in this world today in the Netherlands under what's called the Groningen Protocol. If you haven't discussed it, I hope you will. Groningen, based on the Groningen Medical Center. And it's a bioethics checklist, bureaucratic checklist on which babies can be killed in their bassinets because they're born with a terminal illness or they're born with a serious disability. It is a bigoted and, in my view, heartless bureaucratic checklist, but it is done. It's not technically legal, but infanticide happens in the Netherlands and nothing is done about it. And the Groningen Protocol, just to show you how respectable this kind of thinking has become, was published in the New England Journal of Medicine when it first appeared without criticism. He goes on, non-persons or potential persons cannot be wronged in this way because death does not deprive them of anything they can value. If they cannot wish to live, they cannot have that wish frustrated by being killed. Another author wrote, because many humans lack properties of personhood or are less than full persons, they are thereby rendered equal or inferior in moral standing to some non-humans. If this conclusion is defensible, we will need to rethink our traditional view that these unlucky humans cannot be treated in the ways we treat relevantly similar non-humans. For example, they might be aggressively used as human research subjects and sources of organs. So you can see the bleak, utilitarian, crass attitude that rejecting intrinsic human dignity creates. It leads to dehumanization. And nothing is more dehumanizing than the idea that somebody is killable. That is because we tend to not want to kill humans. Of course, we know there's war and this kind of thing, but the justification is always a form of dehumanization. And that's, I think, are the stakes in the euthanasia movement, and not just the euthanasia movement, but certainly the stakes in the euthanasia movement, as we saw in the Netherlands, in Canada, and in other argumentation, moves us towards dehumanization and less protection. In the United States, just as an example, Oregon and Vermont, at least these two, now allow assisted suicide by telemedicine, so that the doctor who prescribes the poison might not have even personally examined the patient. And you see doctor shopping. That is, if a doctor says, no, I don't want to do this, or I don't think this is appropriate, you'll have euthanasia organizations just refer them to a doctor who is predisposed to for killing as an answer to human suffering. And there are no protections, really. The protections that are supposedly put into the law are specious, they are illusory, and they are often ignored. But once these things get legalized, nobody cares anymore, and the media certainly isn't interested in exposing abuses. But Alex has done a tremendous job in his blog of exposing abuses. I do my best at National Review, the Epoch Times, First Things, and other places to expose the abuses. And I know a lot of you. I know Meghan Schrader's in the audience, and she's been doing some really good work on the disability rights issue. And the people who are attending and speaking at this conference and attending, it's very vital work. And even if it's sometimes thankless work. These attitudes lead to Peter Singer, for example, promoting infanticide. I'm sure most of you already know about him. I'm just going to read one quote from Peter Singer now, and I'm going to talk about him a little bit later again. And Peter Singer is the most famous of these kinds of utilitarian philosophers, these anti-human types, but he's certainly not the only one. He's just the most respected by the mainstream and by the New York Times, for example, just loves him. He just had a piece published in the Washington Post that I'll be discussing. He's very famous, Princeton University. He was brought to Princeton University years ago, not in spite of supporting infanticide, but because of his support for infanticide and his other great causes, animal liberation, which we won't get into today. But here's what Peter Singer said in his book, Practical Ethics. When the death of a disabled infant will lead to the birth of another infant with better prospects of a happy life, the total amount of happiness will be greater if the disabled infant is killed. Please note in that quote that the disabled infant is the born infant, and the other infant that is going to be better off because the disabled sibling is killed hasn't even been born yet. So it's a hypothetical future baby, not even a real baby. He goes on, the loss of a happy life for the first infant, the disabled baby, is outweighed by the gain of a happier life for the second, because the second baby will not be burdened by having a disabled sibling. Think about that kind of attitude and where that can lead. Therefore, if killing the hemophiliac infant, that's his example, has no adverse effect on others, it would, according to the total view, be right to kill him. This is abominable. And I believe that Peter Singer is a bigot. I've accused him and will again of having the same kind of invidious thinking that racists do, again, just different victims. But invidious thinking is invidious thinking. Bigotry is bigotry. And some people have bigotry against religion. Some people have it against race. Some people have it against sex. Some people have it against disability. But we need to fight bigotry wherever it rears its head, because it leads to oppression, suffering, exploitation, and killing. And that is being discussed openly by one of the most prominent bioethics professors in the world, who is world famous and world renowned and applauded throughout the West. And I find it just utterly despicable. By the way, I once was invited to Princeton shortly after Singer got his appointment to speak about these issues, and I went off script. I've got half Italian, and sometimes my Italian takes over. And I was giving my speech in a very measured way, and then I talked about Peter Singer, and I got really angry, and I really blasted him at Princeton in front of Princeton professors. That clip is on YouTube if you're interested. And I was a lot younger then, but if you're interested in seeing it. And afterwards, during the Q&A, professor got very angry with me, and he said, "We had every right to bring Peter Singer to this campus." And I said, "Yes, you did. And I have every right to say it's a national disgrace," because it was a national disgrace. And when Peter Singer was appointed, the disability rights community turned out to protest in force because they saw themselves, properly in my view, as the victims of his kind of thinking, the primary victims of his kind of thinking. So let's take a look at some of the wrongdoing in euthanasia and assisted suicide. I'll just go through a little bit of it, and then I'm going to talk a little bit about Peter Singer's most recent promotion of killing for organs, and then we'll take questions and answers if anybody has any. Although I know most people at this conference are very well sophisticated about this issue. I remember worrying once that well, if we're going to allow euthanasia, why not just have joint euthanasias of elderly people who don't want to, the suffering is in the future. That is, they're worried about widowhood. And that came to pass as well in Netherlands, in Canada, and in Belgium. There have been joint euthanasia deaths of elderly people. It used to be that a murder suicide or a double suicide of elderly people was considered to be a societal failure and a tragedy. And today it's becoming public policy where euthanasia is legal. And one Belgian bioethicist was reacting to one of these cases. And here's what he said: "It is an important signal to break a taboo." He added in terms as calm and chilling as that of a doctor who had killed the this is a piece I wrote, killed two twins who were going deaf, and they were euthanized because of that and going blind. Then the bioethicist: "This can be viewed as a normal way of dying." See, there's a tremendous effort underway now in the media, in bioethics, among the government leaders and so forth, where euthanasia and assisted suicide are legal, to normalize it, to make it seem like that's the proper way of dying instead of dying naturally, surrounded by family with hospice care and so forth. Back to the Belgian. "This can be viewed as a normal way of dying and viewed as such by the community at large. Non-terminal partners, as we call them, also have the option of dying together. It is legally possible. There are no legal difficulties. It is only less well known. People think that euthanasia can only be applied to terminal cancer patients, but the group is a lot bigger. And this is a beautiful example, I can't stand it, that allows us to provide a dignified death to this couple thanks to euthanasia." Meaning these are people who could have lived for years. And instead, because of whatever fears they might have, or one of them was ill and the other wasn't, decided to have euthanasia. One of these cases in Belgium, the death doctor was obtained by the son of the couple, neither of whom were sick. And the son told the Daily Mail, I think was the newspaper. Sometimes the media does report, the Daily Mail in particular will report these kinds of things. He said, "Well, I wasn't going to be able to care for them when the time came, so this is the best choice." Well, I mean, if those parents might have thought, "Well, my son wants me dead, maybe we should die." I mean, talk about when my mother was dying, if she had said, "I should have assisted suicide," and I'd said, "Okay, Mom, it's your choice," it would have made her worst fears seem true to her, that she was worried about being a burden, worried about losing dignity and this kind of thing. So when we acquiesce to that, we're actually validating people's worst nightmares, and that is a form of abandonment. In Canada, there was actually a case of a joint euthanasia death where the father or the husband qualified for euthanasia and the wife didn't, according to the doctor. But then somebody writing about it said, then a miracle took place because the wife started getting sicker and she qualified. I mean, the idea that it's a miracle so you can be killed is really abhorrent to me, but that's what happens when you normalize killing as an answer to human suffering. There was an article in Canada that by bioethicists there, euthanasia should be okay for unjust social conditions. So remember, the concept of suffering becomes highly malleable. And suddenly we're starting to look at euthanasia for people who are homeless or people who are drug addicted and so forth. In fact, let me do this right now. There was a poll that came out a few months ago on Canadians' attitudes. Because when you legalize killing, it changes the mindset of a society 180 degrees, because killing becomes considered good, and the supposed protective guidelines to prevent against abuse that we hear so much about are immediately transformed into obstacles to the good being the killing. And they did a poll, and the poll is conducted by research company on medical assistance in dying in Canada, May 5th, 2023. And the poll asked, is poverty a reason to allow euthanasia? 27% of those polled either strongly agreed that poverty was a reason for euthanasia or moderately agreed. 27%, 1 in 4 people thought that the answer to poverty, an acceptable answer to poverty, would be killing the impoverished person. Homelessness, the same question. 28%, 11% strongly agree, and 17% moderately agree that will put the homeless out of their misery with euthanasia is fine. And by the way, some people might be thinking, well, that's putting us out of our misery because of the social problems caused by the homeless crisis. Inability to receive medical treatment. In other words, failure of medicine, the answer is letting a doctor kill you. And that's 51% said that inability to receive medical treatment is grounds for a doctor to kill you. I mean, if you can't trust a doctor to give you treatment, why would you trust a doctor to kill you? It makes no sense to me. But the mindset of the population is being changed very dramatically because of the redefinition of euthanasia as a public good. Mental illness, which of course next year in Canada will be permitted and is currently permitted in the Netherlands and in Belgium. And many of the people who are euthanized and organ harvested are mentally ill, not physically ill, because they have the best organs. 43% say mental illness is grounds for euthanasia. 16 strongly agree and 27 moderately agree. Disability, 50%, 18% strongly agree and 32% moderately agree. This is a crisis of morality and ethics that a society like Canada, which has always been deemed so humane and so caring, is actually turning to the abandonment of euthanasia for people who are at the margins. It's a very dangerous condition. Canada does not allow children yet to be euthanized. The Netherlands does, and Belgium does, as obvious from the start of this speech. But there have been articles of presented in medical journals saying that children should be allowed to be euthanized in Canada, and that what are called mature minors should be allowed to be euthanized without parental consent and, in fact, notification. And I've written about that if people want to look it up. All of this leads to a very worrisome place, which is death on demand, because we've become so inured to death and start to view death as a positive that if somebody feels they have a life that isn't worth living, and the issue of choice is so paramount, that we should have death on demand. And that has already, by the way, come about in Germany because of a court ruling. Germany's highest court conjured from the country's constitution a positive right to commit suicide at any time for any reason. And it created an ancillary right for anyone who is willing to assist. So there is a fundamental constitutional right in Germany to kill yourself. And it doesn't have to have anything to do with health or disability, but any reason you think, based on personal autonomy. There's a constitutional right in Germany based on this court ruling, which is the highest court in Germany, to having assistance in doing that, and an ancillary right to assisting somebody who wants to die. Quote, the individual's decision to end their own life based on how they personally define quality of life and meaningful existence eludes any evaluation on the basis of general values, religious dogmas, societal norms for dealing with life and death, or consideration of objective rationality. So that whatever a person thinks it means that they should end their life, that is sacrosanct. And rationality and objective demonstration of pain isn't required. So this becomes very, very worrisome. And that's where euthanasia ultimately leads to death on demand. It'll go faster in some places and slower in others. But once you decide that suffering killing is an answer to suffering, and you decide that suffering depends on what the person who wants to die considers the suffering to be, not whether there's any objective tests or requirements of treatment, then how do you not get to death on demand? And of course, the mental illness permission is a kind of demonstration of that. Finally, I'm going to end on Peter Singer again. He just wrote a column in which he said that we should do away with brain death for organ to be deemed qualified as an organ donor, and that we should change that to unconsciousness. So he writes, when is it justifiable to end a human life? His answer, What determines whether it is justifiable to regard the life of a person as having ended is the irrevocable loss of consciousness. Once that has occurred, the person whom family and friends knew and loved has gone forever. But such people are not cadavers, they're patients. That's both basic biology and fundamental to medical ethics. If we're going to start saying that unconscious people can be harvested and deemed dead, even though they're not, that turns medical science from an objective approach to an entirely subjective approach. And if we can do that, why can't we move beyond the unconscious to other people? I'm going to end with a couple of points. This is an article that came about back in '93 when Jack Kevorkian was doing his thing and promoting optometry. And by the way, the media never bothered to tell people about his obsession. They just focused on, well, he's ending suffering. And the media bias is a real issue that we have to struggle with, because it's very hard to get our message out to the mainstream of society, because the media has basically, generally speaking, shut off our access to talking to people in articles about euthanasia, when they talk about suicide parties, when they talk about how this is a person dying on their own terms. The 16-year-old, the article on the 16-year-old, it was a flowery article about, isn't she wonderful for donating her organs, without even asking anybody whether there was a reason to think this was wrong. Not even one voice in opposition. Anyway, this was an article written by Robert Arnold and Stuart Youngner. They're very involved in organ donation issues, and I believe do not believe in the dead donor rule. And they talk about a future that they can see happening, which back in '93, many people thought unthinkable, but I think we can now see emerging. And let me read this to you. It's stomach roiling, but we need to face this. Quote, machine-dependent patients could give consent for organ removal before they are dead. For example, a ventilator-dependent ALS patient could request that life support be removed at 5 p.m., but that at 9 a.m. the same day he be taken to the operating room under general anesthesia and his kidneys, liver, and pancreas removed. Bleeding vessels would be tied off or cauterized. The patient's heart would not be removed and would continue to beat throughout the surgery, perfusing the organs with warm, oxygen, and nutrient-rich blood until they were removed. The heart would stop and the patient would be pronounced dead only after the ventilator was removed at 5 p.m., according to plan, and long before the patient could die from renal, hepatic, or pancreatic failure. If active euthanasia, e.g. lethal injection and physician-assisted suicide, are legally sanctioned, even more patients could couple organ donation with their planned deaths. We would not have to depend only upon persons attached to life support. This practice would yield not only more donors, but more types of organs as well, since the heart could now be removed from dying and not just dead patients. The irresistible utilitarian appeal of organ transplantation has us hell-bent on increasing the donor pool. Giving up the dead donor rule, however, raises questions of how far we are willing to go to procure more organs and at some point save more lives. Are we headed for the utilitarian utopia espoused by Jack Kevorkian, where organ retrieval and scientific experimentation are options in every planned death, be it mercy killing or execution? And he ends, if a look into such a future hurts our eyes or turns our stomachs, is our discomfort any different from what we would have experienced 30 years ago by looking into the future that is today? So these are the stakes. And I'm going to end with a quote from a physician of the 18th century and 19th century, Christopher Wilhelm Hufland, who wrote, "If the physician presumes to take into consideration in his work whether a life has value or not, the consequences are boundless, and the physician becomes the most dangerous man in the state." Thank you for your attention.
So thank you very much. It's a very powerful talk, and you ended it by actually opening up the new question of the issue of the dead donor rule and things like that, which are absolutely issues that are now being debated in a totally different way. As you know, they're not actually saying that we should remove organs but keep the heart beating so we can declare you dead after we remove the heart. They're actually just saying we'll just declare you dead ahead of time, and away we go. So, that's the big push now. Just declare you dead and away we go.
And
So-
there's also advocacy, Alex, in bioethics journals I've written about it, saying, well, if euthanasia is legal, let's just do away with the lethal injection. Let's put people under and have euthanasia by organ donation, meaning
Right.
that retrieval of organs would be the cause of death.
And of course, I've been writing about that also because it makes total sense. Because why would you lethally inject somebody and then take their organs afterwards? Because then you can't use their lungs and you can't use their heart. So if you remove their organs and that be the form of euthanasia, then you can use their lungs and use their heart. So anyway, which would be, plus it's more efficient, as you know, with the 16-year-old. But we can have these discussions all day and make us feel even more happy about what's going on. What I am saying is thank you, Wesley. And you've been, how would you say, I guess in the beginning you would have been called canary in the coal mine. But now with the way things are going, I guess we could say that you were a seer. You could see the future for what it was. Anyway. We don't have time for questions, but we are going to go to Josephine, Dr. Josephine Glaser next.
Thank you, everyone. It's been a wonderful day and great to see everyone here. I'm Dr. Josephine Glaser, family physician with the American Academy of Family Physician. I'm a board member with the Euthanasia Prevention Coalition, female physician. And do take seriously my role as a physician. This is your Michigan House of Representative floor. And in Missouri, we have 6 medical schools and 116 residency programs. In Michigan, you have 5 medical schools and 311 residency programs. So these are your healthcare professional, student and residents, so your future healthcare professionals. And I don't know how many nursing, physician assistant groups there are. So it's a privilege to share about why am I passionate about preventing euthanasia, because as a family physician, I have taken care of families from womb to tomb. And I do ascribe to Hippocratic ethics. And when I graduated from Mizzou Medical School in '96, I took the Hippocratic Oath to do no harm and to protect life from womb to tomb. So, and I was a medical student when Dr. Kevorkian was killing people here in Michigan. And I was like, as a medical student, I was like, what's a pathologist doing killing people? They're supposed to be taking care of or doing slides on dead bodies, not taking care of living people and killing them. So that was totally, I guess, out of scope of practice for him. So he was not only practicing medicine outside of his scope, but he truly was doing illegal, immoral things. So, and of course he had some psychopathology as well. So next slide, please. Objectives for today is to define and describe physician and allied healthcare professional advocacy. Why would we as healthcare professionals, want to be part and lean into, the Michigan Right to Life alliances and engage in state public policy? And what are the practical steps to physician and allied healthcare professional advocacy? Next slide, Emily. Next slide. So I want to tell you my why. Why is some of our other speakers had alluded to that interdependence. I'm a naturalized citizen. I wasn't born here. I was born in the Philippines. My family was we immigrated here when I was 12 years old in Missouri. My aunt, who is there to your left, she is a teacher. She was a teacher for about 30 years. She, of course, sponsored everybody to come to America. And for my family to arrive, it took us 10 years. So we waited our turn before we came. And when we came, I was 12, went to, culture shock when we came. So many choices here in America. And went to WashU for college, medical school in Mizzou. And Married my husband there during third year medical school. We have 4 kids. My first daughter was born when I was fourth year, 2 weeks before graduation of medical school. And my 3 kids were born in Kentucky when I was in residency, but we moved back to Missouri in 2015 when my aunt needed elder care. So it was kind of a calling for us to kind of go back full circle. So that interdependence in family life, that's important to us Filipinos. My parents live with us. So to us, it's like, okay, that's cool. My husband, as you can see, is white. They are very, they're independent people. So my father-in-law currently lives in an assisted living. We visit him about once every quarter now. His mom just passed away about 3 years ago. So his dad, we just check in on him, every 3 months or so. So my Filipino heart says, come on, let him live with us. And goes, nah, it's okay. My sister's taking care of him, like, okay. And the other reason is my Hippocratic ethics, as you see there, the medical associations I'm involved in, the AMA, the American Academy of Family Physicians, the American Academy of Medical Ethics. Currently, we'll discuss a little bit more. The American Medical Association, you all discussed that the state chapter, the State Medical Society, did you say has a engaged neutral or still opposed? Please stay opposed because and we need your help. Those 5 medical schools or 6 medical schools, please alert. Who in here has a doctor? Who in here, anybody have a doctor? Okay, y'all have a doctor? Please make sure this is a good time to talk to your doctors. It's probably a good time to ask them, so do you ascribe to Hippocratic ethics? Do you have a conscience that tells you, not to kill me or that would be good. I think Euthanasia Prevention Coalition has a life protecting advanced care directive. I think the Michigan one, this was great to know that you have a good life protecting power of attorney. Because in Missouri, I think we just have the generic one, so I'm going on a tangent, but the American Medical Association in about a month, the student and resident delegates are proposing for the AMA to reverse their stand and are using the death with dignity terms to change their stand to medical aid in dying and to change our stand to oppose, using the term physician-assisted suicide. It's been proposed in 2018. It was defeated, so we need y'all's help again. Talk to your doctors, talk to the students, talk to the resident. We ourselves in our medical society are gearing up, support. So if y'all are prayer partners or, have a network in Michigan or in any of the 50 states and the other not continents, that Puerto Rico provinces, territories, please tell them to at least register with the AMA because students and residents have low fees, and we do have connect with me. We have people who will support them with their fees and will help them go on the virtual platform. They need to testify on the virtual platform by October 29th, just to say, I'm a medical student, I'm a resident. The student and resident delegates do not speak for me. Just to say that so that they have enough pushback from the student and resident areas to say that the leaders do not speak for the students, then perhaps it won't pass again, So, and then we have enough leader delegates that will say, yeah, we've discussed this. The AMA stands to support our position for the last 150 years. So, because I think that's the last vestige, so to speak, currently. Unfortunately, my academy in 2019, the American Academy of Family Physicians took a engaged neutral position. That's actually when I woke up to advocacy because I was busy taking care of family, taking care of my aunt, taking care of my parents, taking care of my patients. And then suddenly the AFP news says, oh, guess what? Your academy changed from taking a post position on medical aid in dying, and I go, what's medical aid in dying? Is that physician assisted suicide? I was thinking in my head to engage neutral. I'm like, what? So that's when I woke up to, oh, I guess I need to start getting into this and speaking my voice, leaning into the society. Okay, next slide, Emily. So what is advocacy? Just so everybody is on the same page. So as a physician, I was like, well, I'm already advocating for my patient. I'm right there with them, every day. That's how I advocate for my patient, right? Why do I have to get involved? But it turns out when a physician advocates for their patients in the state, talking to their legislature, state policy, or in the federal, they like seeing us. They see us as the expert witness, right? And it's great when I'm with my colleagues too to say, hey, this is important to me. This is why, it's to promote those interests of the individual or a group. And for physicians, apparently this was already looked at 13 years ago, I didn't even know, by Dr. Mark or Dr. Ernest, where it's an action by a physician to promote those social, economic, educational, and political changes. I'm not trying to be political, but it's that social, economic, educational changes that ameliorate the suffering and threats to human health and well-being that he or she identifies through our professional work and expertise. Currently, within the last 5 to 10 years, my young students and residents are talking a lot about those social determinants of health, the impact of poverty in my patients who aren't able to, who have to decide, do I pay for this medicine or do I pay for my electric bill? Currently where I practice in the neediest population of St. Louis in a value-based care model, and they're my elderly populations, age range 32 to 102, average range 72. Many of them are lonely elders because they either are estranged from their family, some of them suffer from substance use disorder, and some of them are living in situations where extreme poverty, they have bed bugs, they have landlords that say, oh, you need to move within a month. And I'm going, why? You don't have another place to go, Oh, they want to renovate this place, just like that other individual that Alex had mentioned. So I'm seeing it, I'm seeing the parallels in the United States, and that's in inner city St. Louis, where you already have a lot of racial tensions, going on. So to me, it's starting to hit home. And then, Meghan's talk about ableism. I'm like, am I an ableist? Really? Am I? I'm like, I think I am. Oh, shoot, sorry, So, but I think my colleagues in my academy are. And so I'm going, Meghan, help, help me, give me the words to speak kindly, professionally, and lean in to my academy to go, these are all, ableist talk. Help me turn the tide a little bit, there. Okay, next slide. So, but why not advocate? Guess what? Time is of the essence. So it takes away from the investment of direct patient care. Those are some of the barriers. So I've been a physician for the last 27 years now, married for 28 years, 4 kids, So, but I feel that calling, my calling is to be a physician. I'm a wife, I'm a mother, I'm caring for my elders. So the calling is there, but again, there's a calling beyond just the caring for others. It's the love for others too. But these are the barriers that I face. These are the barriers that our students face. These are the barriers that my colleagues face. And in the end, it's like there's going to be potential distrust within that patient-physician relationship or other relationships. There's negative publicity, for that physician because it's not really a popular position. And there may be loss of professional advancement, leadership, or employment opportunities, especially nowadays. Physicians usually are in an employed position, so you need to kind of learn how to advocate for yourself. So advocacy isn't just in the healthcare system, component. You need to advocate on how to negotiate your contract, right? need to advocate on how you set up your time to work, advocate for your patient, advocate for the community. So it's like, okay, so those things, then you have to sleep. So yeah, right. And then there's that practical challenge, like I said, lack of time and training. So some of my colleagues too are like, okay, how do we do this? Then just that minor family life work balance, and then other folks too have the belief that, okay, personal advocacy does not make a difference. So we can be complacent. We can be like, the problem is stacked against us. Oh, woe is us. They're winning. Why do we even bother? Okay. Or someone else will do it. They're better equipped. Yeah. Wesley will do it. He's done it for 30 years. He's going to win it all for us. So, and advocacy is for those crazy activists, not medical professionals. So some of my colleagues might be thinking that. And now I'm going, hey, it really takes like that village, right? But also I need that village of my legal colleagues, ethicists, nurses, my disability rights friends and family that can lean into their physicians to say, hey, y'all need to speak for us, too, and then talk to your physicians and say, hey, connect with your life affirming physicians. So I'll give you those resources to maybe equip your physicians and connect with us, okay? And the concern that civic engagement is a private matter. So, okay, next slide. So, but why advocate? So that slide tells you that, look, the students and residents of today are being trained in a very technical way, okay? They are kind of losing that physical touch, okay? And Wesley alluded to it. So it's like, okay, let's just do everything by the book, by the technical way. Everybody who likes, for me, some of the things that I like to do to relax is watch K-drama, Korean drama. Does you all like to watch K-drama? There's this show called Squid Game. Has anybody watched this Squid Game? But it's sad. If you watch Squid Game or any of the K-dramas, actually, the K-dramas discuss this euthanasia stuff, like part of it. And okay, I won't spoil it. Y'all need to watch K-drama, Squid Game. But they discuss how, organ harvesting, and this is from the Asian perspective, is bad, okay? And bad doctors, they put it on there, bad doctors, bad, organ harvesting, bad, okay? So, so that's just how I spend I binge watch actually. So sorry about that. My husband, if he's watching, he's like, yeah, she does. So anyway, but why advocate? So as a physician, I advocate for my patients in a public policy setting because I want to support the needs of the elderly, the vulnerable, the disabled, the marginalized more holistically. Because as you could see there, we are seeing our patients in a fragmented way. Healthcare is fragmented. As much as a family physician, when I was training, I was trained that, I'm going to see patients from womb to tomb. And at first I did, when I graduated from residency. So family practice really is, go through college 4 years, medical school 4 years, residency 3 years. And then, you practice full spectrum. For the first 3 or 4 years, post-residency, I practiced full spectrum until I had my other 3 kids, right? So I needed to choose. And full spectrum meant I took care of mom, baby, delivered babies, did circumcisions in the hospital, saw my patients in the hospital, did what we all now see as hospitalist care. So I did hospital medicine, took care of people in the office, kind of did the family doctor type thing. Now I'm outpatient. So, but I know, I've been there, done that, so to speak. And so now I see my elder patients who are taking care of their grandkids, their great grandkids, or sometimes feel like their purpose is to take care of the grandkids and the great grandkids. Like, that's great, but they have community. But those who are estranged, I'm like, okay, how do I help them be connected to community? So another reason to advocate, of course, is to promote that positive change, that community toward human flourishing in our communities, in our healthcare systems, medical societies, medical education, public policy, and society at large. Okay, next slide. Another reason why advocate again? Well, selfish reasons, support our colleagues and ourselves. Promote that positive culture within the profession of medicine. Believe it or not, reduce burnout through empowering our physicians, future physicians, and enhance their communication and leadership skills. Currently, the American Council of General Medical Education, the American Academy of Family Physicians, and the American Medical Association has noted that physicians or future physicians training in leadership and advocacy is an important kind of competency skill. So it would behoove us to engage with our students and residents who are life affirming and train them in those ways, because believe it or not, Compassion and Choices is training the students and residents to, as you've seen, they're the ones promoting the MAID resolution. So we are mirroring that, or needing to get garner that support to say, there are two sides on this coin. So, and thankfully we have the evidence of time, and we have the evidence of our established colleagues from the AMA who have built that groundwork of this is how we practice medicine. So, and this is where we need to amplify the voice of our Hippocratic student and resident future colleagues to not be afraid, because at this point, our colleagues who have been trained by Peter Singer's philosophy are stepping up to the mic. So next slide, please. Oh, I meant, okay. I was going to skip this, but I am faith-based. So there are also Christian reasons for advocacy. At the grassroots level, we can follow Jesus' example in Matthew 25:31-46, which is to feed the hungry, give drink to the thirsty, clothe the naked, shelter the homeless, tend to the sick, visit the imprisoned, and bury the dead compassionately till their natural end of life, not to kill them. Okay. At the public policy level, we stand in the gap, for the widow, the orphan, the elder, the stranger, the suffering, the ill, the poor, the disabled, and the preborn. In that way, we can influence culture and the community for Christ. In this way, we are promoting the moral determinants of health, not just the social determinants of health. And moral justice, not just social justice. Moral justice incorporates social justice. In this way, we convey Christ's love on a broader scale. They will know we are Christians by how we love each other and how we love others. So the great commandment, love God, love others, love ourselves. The world looks at loving ourselves only. Loving others maybe as a way to go to get kudos. It's like, oh, good job, you took care of somebody else, good for you, but that's a way of still loving yourself. But I think about 10 years ago, my second daughter was maybe second, third grade. We were still in Kentucky. Our children's pastor, I'll give you a story. Sorry, a story's coming up. Our children's pastor told them a good mnemonic for joy. Have you all heard this? So if you do J-O-Y in a vertical way, J-O-Y, it's the way to, so look in your head, J-O-Y, it's a way to kind of just visualize the great commandment. This is how you know you're Christians, by how you love each other. You go Jesus, others, and you. So that's the great commandment. So just a quick thing, but that's how you love each other. But when I share that with my patients with permission, if they only love themselves, J or O, that's like, ugh, it's like, ugh. So if you only love others and you, it's like, oh, oi, it's like, oi, But if you only love Jesus, it's like, ja. So it's not complete. You don't have joy. If you only love Jesus and others, that's Joe. It's not complete, but you need to love Jesus, others, and you. What does that spell? Joy. All right, there you go. All right. Anyway, next slide, please. So here's some books to just reflect on ways on how we can engage the culture. Confident Pluralism by Dr. Inazu is he's a lawyer at WashU, and he's developed an initiative called Carver St. Louis that engages the culture in mind and in the secular setting to kind of just help people engage how to speak, truth and love. The Way of Medicine, written by Dr. Far Curlin. He's a hospice and palliative care specialist that kind of works. He's kind of the counter to Dr. Quill. So is how I see it. Okay. Assisted suicide. I just found this book. Mr. Ewell, he writes about the liberal humanistic case against legalization of assisted suicide. So for those who are non-faith-based, it's kind of a nice philosophical way to counter the arguments. I just want to highlight this other book, Katie Engelhardt, Be Mindful. This is a right to die kind of book that dramatizes, the dark side of right to die, but it says, hey, it's happening. Look at what's going on. People really should be doing this. So just be aware that there's this well-written book by a journalist that just talks about already what's happening in the, like her, there's a dark internet. It's like this is this part of the euthanasia in America. Behind that, if I had my thing, behind that, there's this Advocacy for Life, 21st Century Hippocratic Medicine. So for y'all here in Michigan, if you know medical students and residents, please direct them to that site. It's the Medical Students for Life. Myself and 4 other physicians developed this curriculum a few years ago. It's a 12-week kind of self-paced curriculum. You're welcome to go through it yourself if you want, but kind of goes over the Hippocratic ethic, ways to kind of engage the culture winsomely. And there's also some specific things there on assisted suicide, and state and public policy kind of gives you a deeper dive on that. Okay, next slide, please. So what are the goals of state public policy? Next slide. So when you do advocacy and public policy, we are trying to be purposeful, right? In our course of action, just like you had mentioned, Compassion and Choices has a strategic plan. They're well-funded. So we have a strategic plan. We're not always as well-funded, but at least we've got good hearts and we have excellent groups that are already banding together, and we have a good goal and good purposes. So, and I think it's great, like Wesley said, we all need to be working together with that same goal and connect, Public policy is government action or inaction, that responds to our public problems, okay, that are not being solved in the individual or private sector. Government officials represent us. So it behooves us to engage in that. And that's our freedom, right? I think when I went to DC, it's our freedom to, what is that called? Essentially lobby, but that assembly, no, I guess freedom to assembly or petition, freedom to petition. Yeah, right. Yeah, that use a US citizenship thing. Okay, next slide, please. Okay, and so our goals of public policy is what we're trying to do, is protect the public good by preventing outcomes that can be devastating, unintended, or irreversible. So in the United States, that's great that we have that. We have our Constitution that the Supreme Court is supposed to be reflecting on in their decision-making, right? We have the freedom of religion, press, speech, assembly, what's other freedoms? We have all these freedoms, and we have our right of conscience. In the medical field now, I'm needing to, in a way, protect my right of conscience, to refuse to perform, refer for procedures or for procedures that I will not perform because they're not aligned with the Hippocratic ethic. So And myself and my group of Physicians for Life members within my academy are leaning into our academy for that, to say, look, we love you all, but we disagree in this policy. So, we'll work with you, but this is where our line is drawn. So thankfully, within the last couple of years, we've been able to lean into our academy, and actually our academy has agreed that we'll develop a right of conscience policy, and we're good with that. So, and when we as advocates for preventing assisted suicide and euthanasia work together for that main purpose, for that goal, we're educating the public on those issues too. Again, mirroring what Compassion and Choices is doing with all their bunches of money. We're doing it with our grassroots efforts, but we do it with the education to go, look, this is, and do it with family involved and with the resources that we have, given the truth to expose those lies. Goal 3 is establish those regulations to address inconsistencies or to mitigate problems. Okay, next slide. What's the conundrum of public policy? It's contentious due to the diversity of viewpoints presented, and it is an ongoing process. And public policy, as you all know, does not solve everything. Just like you had mentioned, you all started in the 1990s. You had excellent, you prepared for the physician-assisted suicide referendums, goals to stop it ahead of time. You're preparing already for the ballot initiatives to stop it. That's great. It just have to be prepared. There's in each state. Right now, I just have to be aware Compassion and Choices, their strategic plan seems to be that it can be consistent, because it's not just in the legal areas that they're working. They're also working in the health and human services with CMS too, because appropriations to states that have assisted suicide, money is going to those states. So it can appear that their goals are going to be met, because in the next 10 years, they have money going to states like Colorado, Oregon, Washington, New Mexico for some of the alternative payment models that's value-based care for the poor. So we need to, I don't know how we can lean into that. I'm still thinking about it, but maybe we need help from our other states, who are in there to go, we need to be helping our individuals in those states, because money is already going there. It's already appropriated, for them. So how do we call out those, I guess, policy makers, in those states? Okay, next slide. Okay, what are the practical steps to physician and allied healthcare professional advocacy on our assisted suicide? Next slide. Well, so in the court of public opinion, as you all know, Compassion and Choices and all their allies are very good at that. So we do need to mirror that. Like Alex says, we have that great Fatal Flaws movie. Please keep Googling it and share it to everybody. We have op-eds, start learning to write them. I can reference you some more things, go to these conferences. And because that's where some of these ideas are germinating and growing, and that's where some of our students are getting them. And unfortunately, they're probably getting them in college as well. So we need to counter them in medical school and residency too. Okay, next slide. We oppose assisted suicide and euthanasia in public policy, of course. So as you're doing here, engage in leadership training in your medical association or your local community leadership. So if you're in the public policy arm or in your churches, Christian Medical Association, which I'm also a part of, we have a church resources section. So if any of y'all are part of an active kind of assisted suicide prevention group, our Christian Medical Association has a curriculum called Bridging the Gap that discusses, it's just a good kind of just add water. You can do a facilitated study on what are the ways you could advocate against assisted suicide. Engage in media training. So if you're a student or a resident, or you know a student or resident who's life affirming, connect them with me. I can connect them to CMDA's media training resource. So prepare written testimony. That Advocacy for Life curriculum has an excellent section on media training and doing written testimony as well. So we actually had students and residents in that training that we trained. So they've gone on to do some more advocacy in opposing assisted suicide too. And some of them had written like resolutions, you know, so they're continuing to lean into this sphere. So proud of them. And then testify in person, like Meghan yesterday, she was a rock star. So in Massachusetts, she testified in person, right? Yeah. And, or in over. So, or and testify for me, testify in my medical society. I've signed up for the AMA one. I'm going to do a virtual testimony, just kind of write something up, testify in public hearings. So it's great when Alex and our coalition members, you know, Family Research Council, Patients' Rights Action Fund, American Academy of Medical Ethics, Minnesota Ethical Alliance, you know, our coalition, we work so well together to go, hey team, who's it, you know, who's going here, let's do this. Train to be an expert witness, you know, utilize your gifts and talents when you're called to advocate against assisted suicide and euthanasia. We have equipping for you. We just need you. We need your voice, you know, we need to borrow your voice. All right, next slide, Emily. So what can you do now? So this is for your medical students and residents. So if you know medical students, residents, doctors who you're like, if you know like, oh my gosh, they're scared. They don't know they have anybody, you know, or nurses who feel like there's nobody. We're the only one who's advocating against suicide. It's like, no, you're not the only one. You might feel like it, but you're not. So you got us, you got Right to Life Michigan, you have the Christian Medical Dental Association, the Catholic Medical Association, you have the Physicians for Compassionate Care, and now we have the Alliance for Hippocratic Medicine. So these are all groups that are allied with the Hippocratic ethic, okay? So if you have students, residents, physicians that are going, I'm all alone in this, you know, I can't speak up, you know, just tell them it's okay, dude, do that. You have help, okay? So, all right. And we need, you know, it takes that village of human flourishing. It's like, if we start killing off human beings, like who's going to take care of the whales? So, or plant the tree. So hug the tree. All right. Okay, next slide. And what else can we do now? So for those who, if you know, of medical students, residents, or physicians who feel like, okay, my conscience is being impinged upon, or I can't speak out because I'm being canceled, or I'm being whatever, you know. So there's med law students for life, or I have no idea where to train where my conscience will be respected. There's actually conscience in residency. One of the maternal fetal medicine specialists now who trained at SLU founded this conscience in residency. And then you have these three excellent law firms that's really good at defending life or defending conscience. So Alliance Defending Freedom, Beckett Law, and Thomas More Society. All right, next slide, Emily. All right, and what else can we do now? Well, we have all these fun, you know, y'all know, and this is not exclusive, right? This is not all inclusive. This is just the highlighted ones, right? So we have Caring Not Killing, Patients' Right Action Fund, American Association of People with Disabilities, Not Dead Yet, the Disability Rights Educational something Foundation. So we're not alone, and it's great that, you know, Compassion and Choice can say, ha, we're big, but look at all I think there's power in numbers when they can say, hey, you know, maybe they can talk behind closed doors because they got money, but we have a base of constituents that can say, hey, politician, I'm your constituent. You need to listen to me, not the money. But we should follow the money though, and probably look at the PACs. So I've done my research, and for the medical stuff, just look it up, look at the medical stuff, look at all where does the healthcare dollars, PACs go. You'll see where we lean. I'm like, oh man, so. Okay, next slide. So closing thoughts. Again, I'm a faith-based person, so best as I can, on my own, I cannot do this. So pray. Then usually I pray things that I know from scripture, like Proverbs 3, 5, and 6. I trust in the Lord with all my heart, and I try not to lean on my own understanding, so that in all my ways I acknowledge him and I let him direct my path. And once that happens, God just kind of goes, okay, then I got a plan. As a physician that has been called to medicine since I was 4 years old, I'm not perfect, made lots of mistakes already, but God is good to kind of direct that path to redeem it. So the plans are, to just honor God in whatever I do and prepare. So in the assisted suicide euthanasia prevention, it's prepared to be engaged, in the culture, train, get groups with me. With my academy now, I'm co-chair of the Physicians for Life member interest group. There's about 700 of us now. We started in 2020. So we're leaning into our medical society. Next slide, Emily. So keep protecting your right of conscience, your civil liberties, your civil rights. My family came here because this is the land of opportunity. So, we would hate for those opportunities to be stolen, right up under our feet when we came here for that purpose. And so I'm called to participate and to do what I can to preserve kind of those rights in a winsome way, graciously, and then be at peace about it. It's like, because I'm not the one who's going to solve everybody's problem, but I know the one who is, and the one who I'm responsible to. So thank you for your attention. Any other questions?
And Josephine had asked if we had a shorter, spot here for her. And it's like, she didn't need one because she might be shorter, but she packs a big punch. So it's very good. And she did an incredible presentation, more about for all of us. It wasn't, I was thinking she's going to present from the medical perspective, but she actually presented from more of an advocacy perspective, because everything she was saying about the medical community applies to our local communities, our churches, our politics, our you name it. It applies to the same thing. And it was a good overview because, Josephine's gotten very involved with all these different organizations that she's directly connected to, whether it be family medicine, AMA, etc., and has a great influence because of her involvement. So can you come up, and I'm going to change this over to the next presentation, and then Pauline, and you can introduce
Okay. All right. Yeah, so our next speaker will be Betty Odello. She's a retired nursing professor and president of the Scholl Institute. She has a lot of information in the back. She's going to go over how legalizing assisted suicide changes palliative care. Thank you, Betty.
I want to kind of summarize what we've heard a lot of today. I was so excited to hear Dr. Glaser talk about the Hippocratic Oath, because, so many medical schools are making up their own oath and they don't even call it Hippocratic Oath anymore. And so, yeah, it's nice. It is really true. Anyway, I am Betty Odello, and I am president of Scholl, and there is lots of information back there, and I would be very happy if you pick it up, because I don't want to take it back home. But it's also, there's very good information there. Anyway, why am I speaking about this? I have been in nursing for over 50 years, okay? I started out as a nurse's aide and did the whole thing from staff nurse to head nurse to director of nurses of a large facility out in California. I've also been teaching not only nursing, but philosophy with an emphasis in biomedical ethics. And the reason I got into biomedical ethics was because of what was happening in hospitals. And you'll hear more about that as we go on. So anyway, we don't know a lot about how we're going to die, but we do know that we are going to die. And I can graph it any way I want to, but it doesn't matter because we're going to die. Okay, we have no choice about our mortality, no choice whatsoever. Hey, but that's not all there is. We do have choices. We do have choices. Now, I was around nursing in the 60s when the doctors became aware and able to put a lot of equipment onto people. And this was not an unusual sight in the 60s and 70s. Medicare started paying for all this equipment. Doctors were paid by the amount of procedures and equipment that they used. And so, like I said, this was not unusual. And we did save a lot of people. I do have to say that it was good. And you can still choose to die this way if you so choose, Or you can choose a little quieter. You can be at your own home and you can have a caregiver there and your family might be there as well. We would hope that everybody has a family. But what we want to make sure is that you do have choices. Interestingly enough, since physician-assisted suicide has come into effect, our choices are a lot more serious than they've ever been before. I have been giving lectures for many, many years, but I have to say the last few years, sometimes they're kind of depressing. When physician-assisted suicide first became legalized in 1997, I have to say that probably wasn't the first time people were killed. But anyway, this is when it first became legalized. And how does it look today? Now, it's legal in 11 states, and I think we've heard a lot of this from Alex, and in 4 countries. And amazing what it's done. Do you realize this is only 2023? So about 26 years, how this has expanded. It's frightening, no way you look at it. But people want the choice of a peaceful death. They want a peaceful death. I think it's something we probably all want, but is MAID the way to get it? Okay, so what I'm going to emphasize today is the changes since the legality of physician-assisted suicide. So especially we can look at the prognosis. Many of these things have been mentioned before. I'll just repeat a little bit and then maybe add some little things. And mental competence, voluntary requests, waiting periods, residency oversight. Hospice and palliative care, I'm going to go into, and organ donation. Okay, I question today safeguards. Are there such a thing? Really, honestly, truthfully. You know, when we agreed to physician-assisted suicide, I was in California at the time, and we fought it successfully for 12 years, for 12 different times. But Michigan's done a better job than we have. But they talked about all the safeguards that we had. Then they had to be mentally competent. No doubt about it. You had to be mentally competent. You had to have a psych evaluation. Okay, and you had to have a terminal diagnosis that you had less than 6 months to live. Well, we all know what a terminal diagnosis is, because how many of us have heard that somebody's going to die in 6 months and 6 years later, they're still kicking? Okay, so these terms are variable. But now, they don't even pretend to have a terminal diagnosis. We've heard about anorexia nervosa. We've heard about disabilities. I really want to thank Meghan too for her point. We talk about physical disabilities a lot, but we don't talk about mental disabilities a lot. And I think it's high time we consider that. So that was an eye opener for me to include that a little bit more. No psych consult once in a while. And is it really a voluntary request when you have the pressure for money? Do you know how expensive end-of-life care can be? It's very expensive. Medical costs are throwing people out into the streets. They're becoming homeless. They don't have a car. Okay, sometimes their family disown them because they don't want to care for them. They don't want to worry about the price. Okay, insurance companies will pay for their MAID, but they won't always pay for the care, or they'll put you on a waiting list. I think we talked about that 6 months, 9 months down the way, maybe you'll get treatment. Okay. That's a long time away. This voluntary request, I think sometimes these people are encouraged to accept. They're encouraged to accept, oh, you are a burden to your family. You know what? Your grandkids would really like that money to go to college. Okay. Or maybe we want to take a big vacation. Okay. So there's better things that could be done with that money than pay for you. Listen, I've been in intensive care. I can't tell you how many times I've heard that. I can't tell you how many times. And that, I haven't been in intensive care for a long time because I've moved around, but that was in the 80s that I can remember that. So you can imagine what's happened now. But the worst part is, I think it gives people this idea that maybe they are better off dead. Can you believe that? That's what's happening, that I'm a burden to others. And so listen, Betty, you know, just why don't you move on? It's okay. All right. So the waiting period, I think Alex has gone over this too. We had to have 2 requests. They had to be at least 15 days apart. And then you had to wait another 48 hours before you could get a medical prescription. Now, you see, I have nothing because it varies. And then sometimes, as we've mentioned from a couple of the speakers, it can be up even in the same day, Residency requirements, you had to be of the same state. Well, now we see that's changed, not required. You know what? You get a bargain. You only have to buy a one-way ticket. Okay, so then we look at terminology has changed. This is amazing to me. Physician-assisted suicide back in the 60s and 70s. You know what? It was kind of a disgrace. I'm telling you, why would you do that? You left your kids. There are people that love you. Don't you know that? Do you know what you're doing to your community? Listen, I took the guilt for a couple of neighbors. And why did you leave those kids? We were just, what didn't I do? What didn't I do? Suicide was not something to brag about. It was something that we almost wondered, you did that? Okay. But now, oh, it's death with dignity, mind you. Death with dignity. This is what we want. But the terminology changing, making up medical care is just very frightening to me, because as a patient, I have a right. You have a duty as a physician to tell me all the options that I can have for my treatment. If I have, let's just say, breast cancer. Okay, Miss Betty, you can have a lumpectomy. You can have a mastectomy. You can have radiation. You can have chemotherapy, and you can have MAID. They have a duty to tell me all my options. And that would be an option if we say this is medical care. Oh, went the wrong way. Sorry about that. And there's dignity in dying. They call this choice dignity in dying, but others have talked about that already. Physician-assisted suicide, I think, is seen as the easy way out. Right now, I'm just frustrated. That doesn't mean I can't get over it, but it's an easy way out, and that's sad. There is pressure from insurance companies and families, but it doesn't respect the human dignity, the intrinsic worth of you because you are a human. And I think Wesley went over that very well, so I won't spend a lot of time. He did a marvelous job, by the way, with that. And this is kind of Betty's thing. And I think that somebody else mentioned, I think it was Genevieve maybe, but find out if your provider does physician-assisted suicide. And when I ask those questions, I know that what they say will determine whether I'll stay with that person or not, because I don't want to take that possibility. When we're talking about hospice, lots of changes there too. Dame Cicely Saunders, when she founded it in '67, it was to provide supportive care for the dying patient, ease the pain and suffering, not only of the patient, but of the family as well. And it wasn't about dying. It was about living each moment, each particle of life, every second of your life, the best you can live. Yes, at the end, we know you will die, but let's live first. Let's live. You matter because you're you. Talk about intrinsic dignity. You matter till the last moment of your life, and we'll do everything we can to help you. As the body becomes weaker, the spirit becomes stronger. As a nurse's aide, that's when I started. I was young once, but anyway, it was when I started that, you know, as a nurse's aide, you are really with the patient more than when I was an RN, staff nurse, head nurse, all of that stuff. And I would be with these patients that you kind of get to know and you like, but you did see as their body was weakening, their spirit was, it was amazing to me. I couldn't figure it out. And then later when I talked or read about Saunders, I thought, oh, well, good. I wasn't the only one, but it's amazing what the natural dying process can do to people. But now hospice, not in all instances, but hospice, there are good hospices that continue this. And I want to make that emphasize because the last time I didn't do that well enough. But I have a friend of mine that works with hospice in Colorado. I have two, one's a neighbor, one's a good friend that are getting excellent care that I know, okay, from hospice. But that's not all I'm going to talk about. Because some of these hospices nowadays are not the same. Much of the culture of death has infiltrated it. Because if you know how hospice is paid, they're paid this amount of money, whether when you first go into it, you get this amount of money. And then when somebody becomes critical ill and they need to be turned every 2 hours and they need their IV feedings and they need all of that, they are paid the exact same amount of money. So guess what happens? I got, somebody sent me an article and I can't even remember who it was written by, but just a day before I came up here. And it was like these people that were working with hospice, when it comes close to their end of the 6 months, they're told, if this person is alive tomorrow, we'll know who's responsible. I mean, I can't believe that this is actually happening, okay? It appears that if you've received the money from hospice longer than the 6 months too, then you have to pay it back. It has to be paid back. There's a lot. So what do? They withhold treatment. They withhold medicine. They can sedate actually to cause death. And the reason I'm going to tell you that is because of my grandma Jenny. Now, it wasn't my grandma, it was my husband's mother. But she, delightful person, but she ended up with pancreatic cancer. Okay. And we all know with pancreatic cancer what the end is. Hers was pretty far along. There was no chance of a Whipple or other surgeries. Okay. So she had pancreatic cancer, but she didn't really have a lot of pain. When she had pain, she had this cat, and the cat would go right here, and that would be enough to make her pain-free. Okay. I don't know whether it's the love or the heat or what, or maybe a combination of all. But once in a while, I'd give her a little Tylenol, but that would be it. Okay, so she was in a retirement facility. And so eventually we did get a caregiver, and it was going along fine. Mom was doing great. But then finally, then the retirement center came in and said, well, you know, your caregiver could use a little more help, maybe turning her, maybe getting her moved up, and she'll be getting better care. Well, at that time I was gung-ho hospice. Okay, so prior to that, I had gone and seen Mom either morning or evening, because I would go right by it on the way to work. Okay, then after hospice, I thought, oh, gives me a couple more minutes to work, right? Anyway, so I didn't go in for 2 or 3 days. When I did go in, I said, Grandma Jenny, and she would go. I said, Jenny. She had no idea who I was. She was up in a wheelchair, what was good. But that was all I can say that was good. So I said to my caregiver, what are they giving her? She says, Miss Odello, I don't know. She says, I don't do this. They do it here. So of course I grip myself up and I go out to the medicine room and I talk to the nurse. I say, what are you giving Jenny Odello? And she says, well, we're giving her medicine. I said, are you giving her morphine? She said, well, yes. And I said, and why? And she said, well, we have to treat the pain. I said, pain? I said, I've been taking care of that lady for a couple of months and she has not had pain that needs morphine, maybe Tylenol. I said, I want that stopped. And she says, well, we can't. I says, what do you mean you can't? All you have to do is stop. She said, no, it's our policy that we give the morphine. I said, oh, and you can't sidetrack that policy. She said, no. I said, okay, well, I can sidetrack you. I'm getting out of here. Well, at the time, we were a private paying patient. She was a private. Guess what? I got the morphine stopped. They didn't want to stop the money, because we were paying for her. And so, but she lived another 2 or 3 months. The day before she died, she was in a wheelchair out looking around. There was a grocery store and a drugstore, and the caregiver was taking her around. Now, and she still never needed morphine. That was one instance. My sister, I know that Alex gave you a lot of assistance, but I think when it's really personal, these are things that are happening every day that we don't see them in the paper. We don't see them in the paper. My sister, anyway, she had not multiple sclerosis, lymphoma. Anyway, so what happened is multiple myeloma. Sorry, I'm getting a little ahead of myself here. And so she got married for the first time when she was 70 years old. Do you believe that? And her husband was 80 something. Okay. Okay. So 7 years after they've been married, they were diagnosed with this multiple myeloma and all that. They were a cute couple, I have to admit. But anyway, as she got weaker, she was larger than he was. So when she fell, he couldn't pick her up. So there was a good Catholic hospice there, and they came out and they talked to us. My sisters and I were all there, and they were trying to say all the things that they would do for my sister and what have you. So, okay. So I thought, okay, I know the Catholic facility, they're not going to do anything to her. So that's fine. So anyway, the next day they brought their ambulance over and we took her over there, and everything was good and she was happy, and we fed her. She wanted a hamburger that night. Okay, have a hamburger. We gave her that. My sisters were still there, and my son had just moved up to Minnesota, and we were in Iowa, and he wanted me to help him move the house. So I thought, okay, my sisters are there. I'm going to go up there, and she'd eaten. I thought she's in good hands. About 2 hours later, I get a call after I got up there. Probably took me 3 to 4 hours to get up there. But anyway, then she said, oh, Ursula has taken a turn for the worse. I says, what? Okay, I'll be down tomorrow. 2 hours later, I got a call. She was passed. Yeah. Yeah. Now, I'm not saying, but I did ask my sisters. I said, did they put an IV in her? And they said, yes. I said, does anybody have any idea what was in that IV? No. Now, I want to tell you, as Genevieve was saying here, when I give these lectures, I can't tell you the number of people that come up to me with stories even more serious than my sister. And there are doctors that have hired a caregiver to be around the clock with their people, and it happens to their mother and their dad. And so this, like I say, it's not everybody, but I am saying, if you're thinking about a hospice, you need to choose it carefully. I thought I chose it carefully. Didn't do it. Okay. My sisters, about 2 weeks ago, they said to me, and she died probably 5 years ago. She says, Betty, why weren't you there? Talk about, yeah. Okay. But anyway, there's questions to ask hospice. I have a whole bunch of stuff back there on the Scholl table. I'm the president of the Scholl Institute, and please take them. And I don't want to take them back home. So it would be just fine if you took some, but you really need to ask good questions before you go into any hospice. I'm sorry, I started using this slide probably in the 80s or 85s, and I think it's still true today. Okay, palliative care. This was a wonderful thing when it came in, because it's a field of medicine that aims to man. And I think you, Genevieve, did a good idea with her definition of terms. It was wonderful. Anyway, pain and symptoms for a person facing a serious illness. The nice thing about it was you didn't have to have that terminal diagnosis for 6 months to live. You could just have a debilitating disease or something like that, and it would help you. And you could get treatment as well as getting the comfort care. So because with hospice, you can't get treatment. They just keep you comfortable. But the palliative care, the goal is to keep the patient comfortable, and you can give treatment. Hospitals have palliative care, And you can have both hospice and palliative care, and you can go in and out of these as well. But then there's this little final line now. The philosophy varies. The philosophy varies in palliative care as well. And I learned this the hard way. There are hospitals that maintain very good. And if you know one of those, thank them. They're wonderful. However, there are some that are not that way anymore. And let me tell you what happened is, as I'm a president of Scholl, I have my phone number out. And so I would get called in for ethics consultations. I would do some in person, and sometimes we did it on Zoom if it was a distance or whatever. Well, okay. I usually recommended palliative care because I thought it was all good. I got a call a few days later, mad as hell at me. Mrs. Odello. And it went downhill from there. Anyway, what happened is that they took it was a lady, they took all of her medicine away. No diabetic medicine, no heart medicine, no nothing. This was palliative care, and it was my fault. Do you think I didn't feel bad? Another one called me, and it was a treatment that they took away, all the treatments from this. So I was on biomedical ethics committees because teaching philosophy, that's what they put you on. Anyway, so I talked to these presidents of these organizations because I was distraught. And I said, is it really true that they can use sedation, terminal sedation in palliative care? And they said, well, we don't want to tell anybody, but yeah, it happens. So I didn't recommend that anymore. But anyway, it was disappointing to me because I thought palliative care would be the way to go. Okay, so now moving on, organ donation has changed. And I think that that's been mentioned. I think Wesley especially did a good job with that. When I started that, when I started teaching philosophy, I was 60 or 70s, informed consent of the donor or the authorized medical authorized personnel. And the donor, the patient must be dead. I mean, that was the criteria then, way back then. An oddball say, yeah, the patient must be dead. Okay, and what that meant was irreversible cessation of key bodily fluids. That meant, because see, I was there, I've been a nurse a long time. Like I told you, we started resuscitation teams then in the 60s. When all those medicines came in, you saw, and all that treatment came in that you saw at the first slide, well, then that allowed us to zap people and bring them back. Now, not everybody that came back walked out of the hospital, mind you, but a few people did. Some people had a fairly good life after that. Not everybody, but some did, that we were able to get their heart started again. Okay, now the dead donor rule, as I think Alex or Wesley was talking about, how they're trying to change that irreversible to permanent. Well, permanent is a relative term, we find out. Okay, because if you have a cardiac death, then they're calling it permanent as much as 5 minutes. Some places, I think it's in one of Alex's thing, it can be down to 2 minutes. That if your heart stopped and then you're not breathing, then that is, you're dead, okay? Now, with these resuscitation teams, sometimes it would take 5 minutes or more to get this anesthesiologist here to intubate, somebody here to cardiovert, somebody else to pour medicines. We had to have 2 nurses, one yelling, putting the medicines in, and somebody else, and then we have to have somebody pounding. So it could take a good 5 minutes. Well, now you're dead. So what do? Okay, if I agreed to be an organ donor, they'll cut wherever they need the organs, whichever, at my age, I don't know if any of them are any good or not, but anyway, what happens is they'll take them where they want them, okay? And then immediately they clamp your main arteries to the brain. Well, you know what clamping main arteries to the brain does, don't you? Okay, so then they zap the heart, okay? And the heart comes back, it's beating, and it's perfusing the blood through all of the organs, the blood and the oxygen. Yeah, I know it's horrible. I couldn't even talk about it when I first read it. I agree with you 100%. But guess what happens? Then the person's brain dead. You wonder why? Okay. So you just have to be careful about organ donation. I'm just telling you, things are changing. Am I proving my point? I told you. I told you so. Okay. So now what do we have? Oh, that one didn't go the right way. Okay. Oopsie. I'm having trouble here. What's your position on resuscitation? Okay. Well, we don't know. We didn't talk to him. Honestly, I can't tell you the number of times when I've been called up as a director. What are we going to do? What are we going to do? Well, part of the problem was we only had so many places to put the bodies. Okay. And so we needed to know what you wanted to do with your loved one because we can't store 20 bodies down there. We only had 3 spots. So anyway, but they never had that conversation. Okay. How are people going to know what you really want? Okay. How are people going to know? I've been preaching this for a long time, is you've got to protect yourself and your loved ones. And the advanced healthcare directives are the way to go. No doubt about it, but not any of them, by the way. Why have one? Well, it respects your autonomy and that your wishes. It frees the loved ones from the burden. Have you ever had to make that decision about a loved one? And if you've had, it's not pretty, let me tell you. Frees loved ones from guilt, okay? Oh, I could go into stories. Anyway, respects your values. These are all good reasons. And you know, I haven't found statistics lately, but I'm sure if I looked harder, I probably would. But a few years ago I did. And it was like, I think it was something like 82% or something of, especially seniors, said we should have an advance directive. And it was less than 50% that had them. Okay, so the thing is, you know, nowadays, there's more reason than ever to get that advance directive that somebody knows what you want. But they're called all kinds of things. Living wills came in at first, about the time that first slide, when you saw all those equipment, all those lines going in, and they were good, but anybody old enough to remember Ann Landers? There are a couple people in this room, maybe, okay. Ann Landers knew everything and she had the answer to everything. And all you had to do was ask her and she'd tell you. Okay. And she started really promoting the living wills. And she says, you can get them at the stationery store. And what they were is it says, I of sound mind do not want extraordinary means if I'm terminal. Well, I'm here to tell you, ladies and gentlemen, you are terminal right now. Okay. Every one of you are. So that knock that one out. But I don't want extraordinary. Now, maybe surgery to you is extraordinary. Maybe intubation is extraordinary. Maybe artificial food and fluid is extraordinary. What does extraordinary means? So a living will per se, without definition of terms, without somebody to interpret it, really doesn't tell you much. People say, oh yeah, I have a power of attorney. Well, what's that good for? Your money. Everybody has a power of attorney for your money. But they don't have a power of attorney for healthcare. So it's a durable power of attorney for healthcare where you designate somebody else to make your decisions for you. Now, people get confused and they say Pulse and DNR are advanced directives. They are not. They are physicians' orders. Now, the Pulse, I think everybody know what a Pulse is. You've seen it. It's a bright red piece of paper. And it's got, all it does is checklists. And it either says, I want everything or I want nothing, basically. Yours is different. Okay, well, this is all the states I've worked at. But anyway, so yours is different. Well, then I don't need to talk. Well, somebody else might be on it. Yeah, I've got Coloradoans and Californians on here. Thank you for coming. Anyway, so what happens is it's got a checklist, okay? And it basically says you want everything, you want nothing. And I say, just go ahead and say you want everything, because at the bottom of it, and now this is the ones I'm dealing with, it has a place if you have a durable power of attorney for healthcare, and it says, who's your attorney in fact? Okay, and the attorney in fact would be the one that to decide it. And if there's nothing that they can do for you, then that person can say so. Okay, but it takes precedent right there. Okay. If it's a durable power of attorney for healthcare, it only kicks in when it's incapacitated. I had somebody call me, I don't know what I'm going to do with this person. I don't know. She was a friend of mine. And I thought, okay, well, tell me, give me a little bit of situation about him. Tell me what's going on. And she said, and then, she told me that he was this and that. And I said, is he competent? Can he talk to you? Well, yeah, he told me to ask you. Okay. I said, you know what, hon, you don't make those decisions. You ask him what he wants. Your durable power of attorney, if you are the power of attorney for somebody, you cannot make those decisions if the person is competent. If they go in and out of competency, you ask them when they're competent, okay? It's legally binding in terms of assignment, but leaves decisions to the trusted person, to the person that will be making that decision. And you pick the person. But you have to discuss it with them too, or you have to discuss it with them too. And I was asked one time to be a attorney, in fact, but I couldn't do what they wanted because they wanted to stop treatment stuff earlier. And I just said, I don't think I can do that. I said, I think you better get somebody else, because if you can't agree with them, and I want that somebody else that you picked to agree with you, religion-based. As doctor was here, okay, then get somebody with your religion. It's whatever you think is most important. Okay, the post, it is a doctor's order, so it goes into effect immediately, but it was developed to help health professions, because some of those durable power of attorney are 20 and 25 pages long. Medical profession has no time to go through and read all of these documents that to find out. They just don't have the hours to do that. So the Pulse was developed, and it was a very good objective, very good objective. It's been used kind of differently now. So that's why I just say use it to protect yourself. It can't be legally required. However, there are many institutes now that will not allow you to go to this hospital, this retirement home, or wherever without signing one. And so that's why I say, if you just say you want everything, it'll shut them up. Oh, sorry. And then you can get where you want to go. But it's immediately actionable. Okay, I want to mention that again. Right away, it overrides your durable power of attorney because it's a doctor's order. And the worst part is with this, is it can be signed by somebody that never saw you. Did you hear me? They send somebody up to your room and they are told how to question you. Oh, you really don't want people pounding on your chest, breaking your ribs, intubating you. Oh, and you probably won't live anyway. And so you say, okay, whatever. And then somebody else can sign that, maybe the hospitalist or somebody that has never even seen you. So that's kind of scary. But anyway, okay. DNR, do not resuscitate, is again another doctor's orders. Okay. It is not an advanced directive. It is a doctor's order. I make that clear, and it must be followed. Doctor's orders must be followed. It's a good thing most of the time, not all the time. Okay. There is a time and a place for a do not resuscitate order, but a do not resuscitate order stays on the chart. And some people that are pretty sick and they want to do not resuscitate order are indeed, what we have is that they get better. This body is sometimes strange. It gets better. And then you might want to be resuscitated. But if you have a bad episode, like I've got an arrhythmia, okay, if arrhythmia goes in, I could see my heart could stop. Get prepared, ladies and gentlemen. But anyway, what could happen is that then, that you would live if you didn't have that DNR. So be very careful before you fill in a DNR report. Yeah. Oh, wait, I lost a slide in there. Okay, I went too fast over one. Let me go back to DNR because, I want to tell you the story about, I have a friend and she went to New York to see her mom, okay, who had a heart attack. She went into the coronary care unit, and right above her bed is great big, do not resuscitate. And Marcia said to her mom, she said, I didn't know you didn't want to be resuscitated. And she said, what do you mean? And so she went out to the nurse's office. Marcia, she was a professor of philosophy, of nursing too. And so she went to the nurses, and they said, why does mom have a DNR? Well, she has an advance directive. Well, did you read the advance directive? Well, no, but do not resuscitate. She's got an advance directive, so we won't resuscitate. They hadn't even read the advance directive. So my point is, on a slide that I don't know what happened to, but anyway, is that if somebody is in the hospital and you know they're really sick, check to see if they have an advance directive and ask. Don't wait for a big sign over the door. Sometimes they have, one place is they had colored tape that I worked at because they didn't want to put the words on there, you know, or they put it on their wristband. Yes, they can do that. And so it's just a good thing to check, because also if that loved one of yours goes to surgery or something, you want to take that off. You want to take that off. You do not want it in there, you know, if you're going to go to surgery. Oh, now that's a new one to me. You learn something new every day. Did you hear him? He said that the doctors in Texas and Michigan are putting do not resuscitate orders on the chart without the loved one's permission. I see too many yeses on that. Oh, no, you know, you guys, this is getting worse by the day around here. The culture of death is just actually scary. It's just actually scary. The bottom line is, you know, we don't face the reality of our death alone. If this was a conference on something else, this room would be packed with the expertise that Alex has put together. But nobody wants to talk about this. Nobody wants to talk about this. 2 years ago, I moved into Colorado. Okay, because that's where our kids are. And by the way, my daughter, I want to thank her for coming with me. But anyway, what happened in Colorado, I went to the pro-life meeting because I've been pro-life for several years. And you know what? Everybody around the table is anti-abortion. And so the meeting comes to an end, and I kind of said, well, do we talk about end-of-life care maybe sometime? Oh, well, we've never approached that, you know? And so, but I said, well, you know, respect life is kind of like from beginning to end. And so, yeah, so thank you, Coloradans, that you were with me today, because many of them are signed up for the Zoom meeting. But I think that we sometimes think pro-life is all anti-abortion, and it is the whole life. But nobody likes to talk about dying. Nobody likes to talk about death. I had this friend, she was a professor of English, and she had breast cancer, and she had been through, you know, the whole thing, radiation and chemo and stuff. And she would get very sick, but she'd come back. She did that 3 times. The 4th time, she said, no, it's just, you know, it made her so sick. And she said, no. She says, no. And that's okay. The burden can't be worse than the benefit. And, you know, she'd been through this. She knows what she was going through. So it was fine. But she died shortly thereafter. And well, the husband didn't know what to do. So he called the person that was a office mate with me. And so he immediately ran over there. And the first thing Richard asked is, well, what would Mary have wanted? And he looked at Richard and he said, what do you mean? What, Mary? Why would we talk about that? That would be depressing. We don't know. Why? Okay. We don't want to talk about it. We don't want to talk about it. And that is why you need an advance directive. You need to talk to somebody. You need to do this. And you really need to be there, okay? When people are really sick, because we don't know what goes on in the hospital or in wherever you are, you know, and sometimes, you know, they get really busy. They may not pay attention to their light. And somebody's got to be, and I say you got to watch what medicines they give them too. Okay. That's just kind of my thought. So what I've tried to do today is to just talk a little bit about the changes of end-of-life care and how critical it is for you to be involved and spread the word. And I went to a talk, I have to tell you this. So I went to a talk on this. I was working with another team. And so I wanted to see what the other team did. This lady did a beautiful job about why we should have advanced healthcare directives. Okay. And in the end, she says, well, you know, I've never been able to talk to my mom and dad about it because I was kind of hesitant. And I thought, you just voided the whole discussion. We've sat here for an hour by saying you can't talk to your mom and dad about it. It's not easy. I know when I started talking to my mom and dad, I had to say, listen, I got to fill this out for me. So I might as well talk to you about it too. But blame it on you. Just do it. Okay. And so I've tried to talk about hospices and palliative care. There are good ones. Let me emphasize, be careful. Okay. And palliative terminal sedation. Okay. And remember that PULSE and DNR are not advanced directives. They are doctor's orders and they must be followed. And I have one other thing back there. Because something is legal does not make it right. People say, well, it's legal in our state, so we can do it. It must be ethical. You know, they wouldn't let a law go by that wasn't ethical. Okay. And so no, can't do that. So anyway, so just so sometimes, and there's a flyer back there too, or an essay on legal doesn't make it right by a Dr. Miguel Indor. He was very good. So ensure your wishes will be honored. Talk about end of life with your family. I think it's so important. And thank you.
So I think it's fundamental that you also ended, near the end at least, talked about the fact of being with people. Because I think the culture really has this serious problem where people are dying alone or going through difficult health conditions alone. And then when someone comes in and brings up the issue of medical aid in dying, well, sometimes it seems like the better way when there doesn't seem to be any other meaning, purpose, or value in your life. And just so you guys know, in Canada, every major hospital has what they call a MAID team now. So that means that if you're in the hospital in Toronto and you have a significant health condition, they want to make sure that your right to die is an option that you know about. So the MAID team comes to you, okay? And they come to you and they sell it then. So I get calls now from my supporters saying, you know, when will the MAID team stop asking? The one woman called me up, her husband was in palliative care. And she said, I can't handle this. They've come in 5 times now and asked. And every time we've said no. So how often do you have to ask when we've been saying no? Anyway, I have a few pamphlets at the back. And if you're part of a local group, you should take them. Or if you're if you're in the Zoom meeting, there's the 5 reasons to oppose euthanasia and assisted suicide. We'll send it to you. Canada's MAID program has gone mad. You can contact the Euthanasia Prevention Coalition, get these. If you're in the room, you can take them. Shedding Light on Assisted Suicide in America, and I've got some books back there. But I want to thank everyone for being here. And Colleen, come up and finish with one comment as or a couple of comments as our chair for EPC-USA, and then we'll end the event. And thank you for joining us, especially the many who are in the room, but the many who joined us for the day online. I know maybe it's easier to be there online because you're in your own chair. But I mean, the fact of it is that, well, we didn't have to give you lunch if you're online either, so it's easier for us. Oh, you come up with, yeah, but the $30 just covered your lunch. That's all it did. So if you want to make a donation, that can cover the other expenses. Colleen, come up, please. We don't have time for Q&A, but people can send an email to us. They can, Colette just did a wonderful conference. Thank you. Thank you very much, Colette.
And please do check out the Scholl table. There's a lot of good articles. I won't go through them all. If you're in the room, not you. And do take what you want so I don't have to take them home.
Oh, you're welcome. All right. My gosh, I don't know about you, but I think it was incredible speakers we had. Online and in the room, just thank you so much. I think we got a lot out of this. It seems like this state, you guys have been such great fighters in the past. So I'm going to be praying for you and behind you. And I know everybody in on Zoom too, from all the states and around the world knows we've got to stop this. This is not the way to handle life. Thank you.